Welcome to this very special recording. When my good friend and colleague Julie Horn experienced my 8D lip design course, she loved the 3D elements and the technique detail, but she was also intrigued. What would happen if this entirely new way of teaching was combined with her own world-renowned lip mastery? So we decided to make it happen. We streamed Julie live from her clinic in Switzerland, and I worked with her from my clinic here in Cheshire to apply the 8D approach to a lovely patient called Scarlett, who you're going to meet. Standing over my shoulder, Julie uses my principles of 8D lip design to direct my injections. Hopefully you'll notice some cool camera angles too. When we filmed previously, I've always been frustrated that I couldn't capture enough detail. So we invested in an expensive new camera lens that gives an amazing close-up view of injecting. I'm going to cover consultation, the 8D analysis with three-dimensional graphics, and then injecting with Julie directing me. I hope you really enjoy this fly-on-the-wall style of learning experience and find it immersive. And I hope it gives you new inspiration and confidence when you treat your next lip patient. Don't forget to download the included PDF treatment plan so that you can follow along with Julie's direction. Let's dive in. We do inject differently, and so you guys are going to get to see me as the student and Julie as a teacher. And this is something else which you hopefully will take from this is I made a decision a few years ago to stop being focused and territorial about my techniques and instead to open up and just try and learn from everyone, because it doesn't matter what you see, even treatments you don't like have something you can learn from them. And through taking that approach, you get to be a much broader, much more sophisticated and a wiser injector. So I'm putting myself through that in real time. We're going to go and do some things using products that I actually don't normally use and injection techniques that vary slightly. Of course, there's lots of similarity, but I think that's going to be an interesting learning experience as well. Okay, so let me just cover what we're going to cover in a bit more detail. So we're going to go through quite a lot tonight. I'm going to explain, first of all, what the concept behind 8D is so that you understand a bit more, the 8 dimensions of lip design, which I teach. Then we're going to go through the first 5 domains of that with our patients. So we've already interviewed our patients, and we're going to go through in detail, heard the most important of all the dimensions of the first 5. That's the patient's motivations, their hopes and fears along all the things that you need to make decisions about. Then we are going to let Julie analyze her face, and you get to hear Julie turn into words what we see. This is one of the most important skills that you can develop, is to understand how to turn into words what you see. And patients really struggle with this. This is why they poke and prod and push and do things in the mirror, is because turning into words is really hard. So to hear Julie do it will be a fantastic thing to listen to as well, because it's one of the skills we all need to develop. Then we're going to go into a detailed analysis of her technique. So Julie's already prepared a plan, and I'm going to interview and find out what is the purpose of these different moves. How does an injection that's horizontal in this plane, how is it different to a vertical injection in a different plane? So we really want to bring the detail alive, this precision. I think what happens with a very experienced injector who's done tens of thousands of treatments is you get a lot of wisdom from very small differences. You have an instinct that develops. And if you can pull that out of an experienced injector's mind, you get that wisdom basically without having to go through as many years of trying to find out how these things actually work. We're then going to do the actual procedure. So I will follow Julie's direction. We've got, obviously, as you may be able to see off camera, but we've got tons of equipment here trying to capture this from every single view. So you will see the procedure, and you can be taking notes and making note of the questions you're going to ask after the procedure as we go through that. And then, because we're going to do the Q&A after the procedure. So as soon as the procedure is finished, we will take our model Scarlett off, who is just out of shot here. We'll get the before and after pictures taken, and we'll do a Q&A. And then there is one more chance. I think most of you probably have already got my 8D program, but for anyone who hasn't, there is we'll give you the link if you wanted to buy it on the last few hours of our Black Friday sale. And then in a week's time, you're going to get the PDF version of tonight. So it looks a little bit like the book. We're broken down. We're going to break down every single step and all the injections that go with it and all of the components of the psychology and the anatomy, and put it all in one document for you, which I think will be like nothing you've ever seen in terms of a training document. Super, super valuable. So that will come out in about a week. We're aiming for a week, but depends how much stuff we produce, but you'll have it. I can see my staff saying it's in a week. Okay. So just to my left here is Scarlett, who is already in position under our crazy close-up lens. So Scarlett has wonderfully shared her whole story, and I think it's a beautiful story. If you have ever wondered, I'm sure there are people on here who wonder about younger people having lips. Scarlett gives a fantastic reason behind it, which we had to dig for because it's tricky to get to the bottom of the motivation, but that's what the consultation is all about. And I hope you will appreciate her volunteering to share that with us for your learning. Okay, so let me go a little bit more into the 8D concepts. I want you to understand the core reason why there are these 8 dimensions is we need a framework to make good decisions when we're doing procedures, because you can make decisions around all sorts of energies, like the patient asked for it, or their mom said they wanted it, or they had an issue at school, or they'd had a best friend who had a treatment, and they come and ask you for these things. Sometimes it's just their budget. I can only afford one thing. What can I have? You know, these are really bad. Some of those are really bad ways to make a decision. You need to be grounding your decisions as a medical practitioner around the right dimensions. And the 8 dimensions are essentially the decisions, a decision-making framework that you can use that to the patient is that you are designing a solution specifically for them. There is no one else in the room, and you're not implementing the same old technique that everyone else does, but it's a beautiful bespoke answer to their complex question, because everyone is asking a complex question. It's not a simple question of how many mils can you fit in my lip? It's how do I feel more confident? What do I do when I feel more confident? How do I want my life to change? What am I striving towards as a person, as an individual? And what is my aesthetic? What's my anatomy? What are the risks? What are the things I'm afraid of? If you can get all of your decision-making built around the right dimension, you will be by far the most popular injector in town, because almost no one does this well. And it's something I discovered it took me probably 10 years to get to this stage of breaking it down into these components. And when you can do it, your patients absolutely love it. In fact, the first thing Scarlett said when we finished the consultation was, that was a really lovely chat. And what she means is she feels listened to, understood, validated, and motivated to go forward with the procedure. There's no better frame of mind to get your patient into than feeling that they are in the right place, doing the right thing to move their life forward. So that is what the 8D framework will do, but it's got all the technical elements as well. Because of course, we're also making decisions around product, and whether it's projection, definition, angles, proportions, the instrument that you might use, all of that is also part of the 8D program. Okay. So without further ado, let's go into the consultation. This for me is the heart of everything we do in aesthetics. And as we go through, I would really like you to listen out for what Charlotte is trying to say, because as I watched this, I've watched this several times since, trying to decide how best to package it. I realized that the message is actually quite clear, but quite often we're too busy kind of focusing on the wrong thing. But there's a key moment in this consultation where Scarlett articulates something and I say something back and she says, "That's right." And if you ever have a patient say the words, "That's right," it's a very important set of part of the language. It essentially means you are seeing the problem from the same position as I see the problem. It's an objective description. It's not saying you're right. It's saying that's right. We are standing in the same position, seeing the problem in the same way. It's the most powerful position you can get yourself into as a clinician if you want to positively influence people. And it took a while to get there. But as we go through, you can see the 8 dimensions on the screen, the first 5 of them. But listen to what she's describing and see if you get a clear vision of what her story is and whether the treatment is justified given what she says, because that's really what the consultation is all about. So let's play the consultation. Welcome, Scarlett. Thank you so much for coming. So it might help you to, before we dive in, for you to understand a little bit about how I like to do things, which is, I know you're thinking about having a treatment, but it's really important to me that whatever treatment you do really makes things better for you in as many ways as possible. So that involves understanding a little bit about your life and how this treatment basically will fit in. And although I am technically the expert on faces, I'm not an expert on your life. So I need your help to help me decide what is the best treatment for you. Welcome, Scarlett. Thank you so much for coming. So it might help you to, before we dive in, for you to understand a little bit about how I like to do things, which is, I know you're thinking about having a treatment, but it's really important to me that whatever treatment we do really makes things better for you in as many ways as possible. So that involves understanding a little bit about your life and how this treatment basically will fit in. And although I am technically the expert on faces, I'm not an expert on your life. So I need your help to help me decide what is the best treatment for you and how this is actually going to serve you. And you knowing that yourself can actually make things much clearer for you in terms of what you do next. Because
my working theory of humans is that you're here for a very important reason, not a superficial one. And I just need to figure out what that is and then make sure it's in alignment with whatever we do. So do you want to tell me a little bit about your journey so far and why you've come today?
Yeah, I think that I've just turned 31 and I feel like, you know, I think there's lots of things that I've started thinking about as I'm getting older. I'm like noticing things about myself. I feel like my face is changing, like, not that the way that I look is the most important thing, but I guess it's the way that it makes me feel. So getting older and seeing how I'm changing, I guess, is impacting maybe how like I perceive myself, maybe how I believe other people are perceiving me. So I've just started thinking about looking into, you know, having some things changed to sort of combat that.
Was there any particular trigger? Because obviously this journey is a long one. Was there anything that made you think now's the time? Anything has changed or triggered you to think more about it?
I think for the last few years, there's just been lots of different things about like my face that I've wanted to change. Like, you know, I'm noticing lines here, like, oh, that's a little bump there, or oh, that looks a bit flat. Like, it's just sort of like, yeah, something I've been thinking about for a number of years, but I've never really done anything about it. And I think it's like the age thing that triggered me. I was like, oh, I'm getting older. My face seems to be getting flatter.
So your birthday's coming up. We just talked about. Is it this?
It was on Tuesday.
On Tuesday, okay.
Yeah.
So that's often a trigger. There's a moment of reflection, and
yeah,
that's okay. That makes sense. Are there any situations in your day-to-day life that trigger some of those thoughts? When is it in a normal week where you think, you know what, maybe I should think about having a treatment?
Well, I work digitally. I'm always on Zoom. I'm always like, you know, you can see yourself in like the corner on the camera, and I think like, yeah, I guess in the last few years, I have spent more time like looking at myself like on a camera, and I just think like, you know, a lot of the times I look and I'm like, oh God, is that what I look like? Is that how other people see me? And then I start becoming that like critical part of myself then comes out. So I think that like since the pandemic, that's definitely changed a lot of things, even though necessarily we've been sort of not as outgoing as we usually are, but just like little things like that. That I think, yeah, every day play into it. Turn, you know, what is it? You can turn like the blurring up on Zoom. So I'm just like, blur it all out. I don't want to look.
Okay. So on the flip side, are there moments where you're feeling your best that you're kind of using as a reference point that we're hoping to get to? So can you picture a time where you think, if I felt great in that situation, that would really help me enjoy life more?
Obviously, when I'm wearing like lots of makeup and I'm, you know, you can enhance the way that you look and you can sort of, you know, change yourself that way. I feel a lot better, but I don't really tend to wear makeup that often. So I feel like I would always want that, you know, you can't be under that filter like 24/7. You know, it's just to be able to sort of have the confidence that you do in the way that you perceive yourself like day to day, but without having to sort of like throw loads of stuff on your face or be under a certain light. To be able to be myself, I think that's like where the treatment comes in. It's like I want to just be able to get up in the morning and I want to be able to like look in the mirror and be like, I'm happy with how my face looks without having to like mask things.
Okay. So it's there's natural in terms of not having to put loads of time every day into preparing, and looking natural is important.
So yeah, really important. Yeah.
Yeah. So that's really helpful to understand as well. Okay. Are there any specific situations where, so it might be worth understanding sometimes how your brain works is it throws out a little like a fantasy of how things could be. And I often think your subconscious mind is trying to lead you towards your potential. So are there any little moments where you've thought, if I have my lips done, for example, and I feel great, that'll be a more exciting or a more interesting, a better moment that you could share with us?
Well, I just feel like that one like insecurity that I have, if that's like, if I overcome that, then just I think me generally like you know, when I'm out with friends and I'm smiling and pictures are being taken and everyone's doing selfies, and, you know, like, I feel like I will be just more confident to be like more present in that moment. Whereas usually I'm definitely really critical. Like if we take a picture, I'm usually the one that's like, no, take it again. Like it looks awful. And I feel like I hate being that person when I don't know like what my friends see. Like they probably see and they think, oh, like she looks lovely and she looks happy. But then I look at it and I'm like, oh God. And I just think like I don't like being that character. I don't like being that person. I want to be like the rest of my girlfriends who like we take the picture and everyone's like, oh, we love it. Like I want to be like that as well.
Okay, that's interesting. The use of the word presence. So, and that's a lot of what I think facial aesthetics is really good at. Sometimes is it takes away your internal monologue, the fear, and it just allows you to be in the moment.
Yeah.
So that's a nice goal, because then you can have that as an image to work towards. So if you have the treatment and you're going out and you're celebrating something, or you're just having a party or whatever, having fun, if you can turn off, to at least dial down the internal monologue, you can be more present. And that's a good goal for you to have, at least in your mind, in terms of what a good outcome will be, which is if you're in those moments, you can basically just be enjoying the contact with your friends and the presence. Have a quick look at the camera, hopefully like what you see, and then move on with the night, just enjoying it more. And it is literally dialing down the fear center in your brain, because that's basically what you're describing. Is there's an element of vulnerability, which if you can turn it off, you can just be more in the moment. So that would be quite a good goal to think about if you go ahead and have a treatment, that in those moments, that's how you justify the treatment, is that you throw yourself into that moment and don't worry too much about those other things. At least worry less, because it's hard to turn it down to zero, but worry less. Okay. Anything else that you're hoping? So I couldn't piece together before we started. Are you single, like on dating? Is that part of your life that you think this is relevant to, or is it more about friends and socializing?
I don't really feel like it applies to like my dating life. I feel like me as a person, I am not very what's the word? I tend to like people for like other reasons than what they look like, and I always assume that anyone who I'm dating does the same thing. So in that respect, I feel like it's not necessarily for me to sort of move forward with relationships. It's definitely more about like self-image and just like how I feel just like day to day in my life. And yeah, like with friends and just sort of like being out and being present and just being comfortable. I think for me personally, like I like value connection beyond the physical, I think, especially with partners. So I wouldn't, not that I wouldn't value, but I wouldn't prioritize like a man's or whoever it is that I'm seeing, their sort of like opinion on how I look. I think that I value like communication and connection and all those other things, that they're of a higher value to me. And if it was as sort of fickle as that, then they wouldn't be somebody I would be pursuing. So I think that, and again with my relationship with women, like I think I value lots of things that aren't necessarily of the physical with other people. So I like assume it is that in return. I just think that it is definitely my own voice that is probably a lot stronger in like my perception of myself. Yeah.
So that's interesting. So what I'm getting from this is that sense of connection and presence is really important to you. And so the physical is a minor obstacle for that. And if you can get that voice to quieten down by correcting some things, you'll have more connection and presence with people. And that's the most important thing to you.
Yeah.
Is that right?
That is right.
I feel like we've got to a nice place, which is I now understand how important connection is and how that relates to the physical. Now I need to understand, in terms of what you have perceived about yourself in detail, the actual physical, what it is that is interrupting that flow. So these are the little thoughts of, this is slightly how I wouldn't like it and where you can see potential. So would you mind telling us a little bit about, if I get my mirror, sorry. Would you mind telling us a little bit about what you are perceiving, and then we can see how that fits to potential treatments?
Okay.
Okay.
Yeah. So like when I'm actually smiling, I think that like, I don't know, I just feel like it just looks a bit flat and weird. And I, because of that, like being with people, like I love being like happy and having a laugh. So when that's happening and I'm always like this, I'm like, oh God, this is really weird. This just looks like it's just gone. Where is it? And then I find myself then not naturally laughing and smiling. So I'm like, oh, that looks weird. Like, what if someone took a picture and then they've got a photo of me doing that really weird face, and that would make me feel terrible. I would probably say it's like one of the main things. And I just feel like from the side, maybe because my nose is a little bit bigger, my lips feel really flat. And I mean, I really do like the shape of them. I think the shape is really not like, I'm happy with the shape. I just think that they look a bit, yeah, just like when I see pictures, I feel like they look uneven and I feel like they don't look, like this bit I find is really weird. Maybe it's just the colouring because there's nothing on them. They sort of disappear in here. But yeah, I think the main thing is that they just seem to disappear when I'm like laughing and smiling, and that makes me feel really weird. Yeah.
Okay. So you have a moment of self-consciousness during probably when you should be in the most present, which is when you're really laughing your head off about something.
Yeah.
It can be a moment of like, well, don't do that too much, because when you were pointing, I noticed that you pointed with your nail like at your gum. Is it the visibility of gums is part of it?
Yeah, I think it is, because like I've had problems, like I've had braces and all that other sort of stuff, like with my teeth. So I feel like in this area, I'm very self-conscious. Like I usually sit with like my hands over my face, like over my mouth. I just think in this area, there's lots of things that I don't feel just comfortable with myself. So like I've had my teeth like fixed to sort of overcome that. And I guess, yeah, like I don't know whether the presence of the gums makes me feel like all I'm looking at is my gums, like I can't, where's my mouth?
Mm-hmm.
So I don't know.
Okay, so it's the top lip that gets thinner as you smile, and the showing of gums is probably number one thing that you notice. Is that correct?
Yeah, I think so.
And then you also mentioned flatness. Is the flatness all the time, or is it more when you're smiling that you feel like it's rotating inwards in such a way that it becomes flat?
Yeah, I think that's what it is. And because I'm always laughing and smiling and, you know, being ridiculous. Like I feel like it's like I'm quite often in that state where I'm having a nice time or laughing about stuff. That's why I feel so conscious. So.
And then in terms of the lower lip, you mentioned something around, is it the fact that you have less, well, basically you're dominant in the middle, so the middle part of your lip,
Yeah.
which is lovely, by the way. That's actually a good feminine lip, does kind of fall out, but you're saying laterally that there's not enough lip there, and you would prefer if there was just a little bit more pink towards the sides.
I feel like the balance is off. But I mean, I could be wrong. But I just feel like the balance is off when I look at it. I don't know whether if like my actual lip is like here, but I just maybe it's just like the coloring of it that is actually like.
Okay, it just helps to understand what you're perceiving. So there's a slight, I use the word like disharmony between the middle and the lateral side, the side.
Yeah.
And we can, when we come to presenting the plan, we'll describe it in more detail.
Yeah.
But it helps that to understand what you're perceiving. You've also said overall, if you feel like your mouth is slightly small compared with other features.
Yeah.
Okay, so that helps as well. So and that's a good guide generally, that lip filler is probably going to be a good thing rather than a bad thing, is if you have a proportionately slightly small mouth. Top lip to bottom lip ratio, how do you feel about the size of top and bottom lips?
Yeah, I mean, I feel like overall the ratio between them isn't something that has concerned me. I think that, not that I want my lips to be like the main focus of my face. I think it is, yeah, like especially from the side, I definitely feel like they feel small in comparison to other features. But I suppose the size of them, I wouldn't say that I would want either of them to be bigger than the other, if that makes sense.
Yeah. So it's when you smile, your top lip gets proportionately smaller though. So it's a different way of describing the same thing, that you could have a little bit more volume in your top lip so that when you smile, you don't have it basically maintains the harmony a bit better.
Yeah, that makes sense. Yeah.
Okay. And then you also mentioned unevenness. Do you mean there's some asymmetry that you can see?
Yeah, and you know what, when I look at them now, I feel like I can't see it, but when I look at myself in pictures, I feel like I can. But I do just feel like I've just generally across my face, there's lots of and like I don't feel like it's very symmetrical. So, but I don't know if you can probably see that better.
So there's always a little bit. I don't see it talking to you normally. I would never pick out asymmetry, but you can definitely study a photo and you'll see asymmetry in everyone. So yeah, that's really helpful. We talked about dynamic when you're smiling and how that affects you. And that's really also gives us a nice goal, which is if I can dial down that and just let you laugh for longer, that's a nice gift to give someone. So without thinking about it, that's a nice goal. Then I think I understand in terms of projection, top lip, some of the detail around your lower lip. Yeah, you have amazing definition. And that's one of the things when I first met you, I thought like, I have to be careful not to change that. So that the detail around your top lip that's what everyone wants. So we'll have to build it into the plan, how not to upset any of that. Because obviously if it spills over into the white part of your lip, you can actually hide some of the detail, which we normally try and create. So, but that's fine. We'll build that into the plan. So I think I understand why you think about having the treatment, what you've perceived, and it all sounds like we can get it in alignment with a treatment plan. But obviously there are side effects and risks, and there must be things that you're afraid of in terms of having treatments. Do you want to tell me a little bit more about what would make you put the brakes on this procedure, or what has stopped you doing it sooner? What are the fears that you've had about lip filler?
I guess it's just because like everyone does it, and I feel like I don't want to look like someone who's had it, because there's lots of people that do get it done and it doesn't really look too great. Also, like just generally having a change in my face, because I'm always so like natural all the time. I feel like it could be like an enhancement that maybe stands out and throws off the sort of like the balance of the rest of my face being natural. And yeah, I guess like again, like other people being like, this isn't you, like you. I think everyone who knows me knows that that whole like natural thing is important to me. I guess like their sort of concerns of why I've done something could be something that might make me feel just generally like, I don't know what the word is, not like uncomfortable, but like just again make me question whether I should do it or not.
So part of your identity is this word natural you used quite a lot.
Yeah.
So what you're saying is if it's overdone, it's going to jar with your identity. So if people can say, oh, I see you've had your lips done,
Yeah,
that's going to be something that doesn't make you happy, because it's now jarring with other aspects, other values. So it needs to be on that side of the treatment scale where certainly once it's settled, because there will be a swelling period where it will be obvious that something's happened, but once it's settled, that it becomes something that you reveal to people if you want to, but if you don't want to, then you don't have to.
yeah, I want it to be like a little secret. Yeah.
Okay. What about side effects, risks, complications? Anything you've heard of that worries you about that side of things?
Well, I guess, yeah, like when you mentioned about it sort of like spilling over, like I've seen it when people, like it sort of migrates into different parts of your face, like that terrifies me. Or just like generally anything going wrong. Like I wouldn't want, like, you know, you see on the internet where people end up like losing parts of like, you know, the tissue, and that's quite scary.
Okay, so we'll talk about that as well to help you make the decision about whether you want to have it done. So swelling and bruising didn't come up on that list. Is that something that worries you? Is it something you can work around if you had a bruise for a few days afterwards?
Yeah, I don't think bruising bothers me. I think like initially swelling might make me be like, oh God, they're way bigger than I thought. But like obviously if it reduces and I know that the swelling, I think that that's like a temporary thing. I think it's more like long-term effects that I think that worry me more than short-term.
Okay, yeah, you're right about those things. So it may look obviously treated. Some people go back to wearing masks. Up to you. But in terms of the side effects and risks, let me give you some information now, and you can use that to make a decision as well. So the lost tissue issue is obviously the worst thing that can happen, and that comes from blocking a blood vessel, and then typically not treating it in time. So that usually means leaving it for days or weeks without trying to reverse it. So I only use reversible products, and you can inject something that dissolves it. I'll also be injecting in a way that has quite a low risk. So Julie Horn is going to be directing. I know she's never had one of these issues of vascular occlusion. I've had one in 13 years, which I diagnosed immediately and treated immediately, and there's no scarring. So it's very low risk, but it's on the table as a potential outcome. But only a small part of it is when you get filler in the vessel. The other elements are, do you diagnose it quickly and do you treat it comprehensively? So I can say that absolutely, you know, my record is very good for that, and I'll be doing things on the day to make sure that blood flow is normal, and we'll be prepared if there was a reason to reverse it, to actually go through that process as well. Okay. Do you have any allergies to anything?
Penicillin.
Penicillin, okay. Anaphylaxis or rash or milder than that?
Well, when I took it last time, I came out in hives. I was vomiting a lot, and I collapsed and had to go into hospital.
Okay, that sounds pretty bad.
Became unconscious.
Okay, yeah, sounds like anaphylaxis.
Yeah.
But nothing else, only penicillin. You know. Okay. Any medical problems at all? Taking any medication regularly?
I don't take anything now. I don't have any problems that I know of.
Okay. Pain threshold? Seem quite laid back. I can normally tell.
Yeah, I feel like, I feel like it will be fine.
Okay, great. That's a big part of it, being fine.
Yeah.
Okay. Do you ever get cold sores at all? No. Okay. So in terms of overall risk, by the way, it's about, they say the published data is 1 in 6,000. My rates are way better than 1 in 6,000, but it's still very low risk of getting filler into blood vessel and then needing it to be reversed. That's the main one to know about. And if you were to have a problem, you can essentially have my number via Layla, and I'll come back and reverse it anytime. But it's very unlikely you'll need that.
Yeah.
The main one to be prepared for would be swelling and a bruise, or more than one bruise. I don't know exactly how we're going to do it because Julie's doing the plan. But we'll take into account everything that you've said to try and design something that's perfect for you. And perfect for you doesn't mean 0 side effects. It just means a good balance of, you know, if we're going to do something, there should be a very good reason for it. So that's the plan. I'll probably be able to get back to you with that plan when Julie sends it back, or there is that small chance that she'll say not suitable. I don't think she will. And then we will, and then you can make a decision then if you want to go ahead with it. The sooner you do that, the better, obviously, for us. But I want you to be in that state of mind of, yes, this is the right thing for me and I want to do it.
Yeah.
Okay. Any questions so far? Anything popped up?
I don't think so. I think, yeah.
Okay. If you have anything between now and then, just get in touch with us and fire away.
Okay.
Okay.
Yep.
Welcome back, guys. I'm keen to know how many of you really have a much better understanding of our patient, because this is a much more detailed consultation than most people would go into in a normal clinic environment. But I know from talking with Julie about how she does her consultations and how I do mine, that this is actually quite normal, particularly for the first consultation, where you really get to know your patient. Now, if you think about what we just went through, the patient who had never met me before told me about some very intimate moments of struggle and conflict, which I then validated and expressed that I sometimes throw in what my experience as a human is as well, to validate that experience. And then we talked about how to move forward from that. So it's very unusual in your life to have someone listen to you carefully and reflect back what you're going through, because the truth is most injectors don't need to do that to know where to inject. Julie and I could probably have just started injecting her and probably got a nice result that we could put on our Instagram. But if you hadn't gone through that process, the patient is highly unlikely to be far less satisfied because they don't feel brought along with that decision-making process. So what you've just seen is my decision-making process, where it is partly about me understanding and a lot about me demonstrating my understanding to the patient, because that's where you unite as a team to go forth and go into the uncertainty of a treatment, because all treatments are uncertain. So we've built a bridge of trust that we can then do work across. Okay, so for me, I thought that was lovely the way we got to this point of it's really about connection and presence with other people. And I love that story because so many people outside of this industry will tell you that it's a superficial and vain industry. And really what we have are people just trying to connect with other people. And if you can remember that, you're going to be way ahead of your competition, who may even be slightly cynical of their patients and think they are just about the appearance. Okay, so now I'm super interested to hear Julie describe what she can take from that, from the aesthetic. Well, we can touch on the consultation, but I also we'll share the 3D image that we've taken of Scarlett so that we can dissect that and decide what is the best way of moving on to the next stage, which is treatment planning. Hi, Julie, welcome back.
Hi, Tim. Thank you so much. What a lovely consultation.
Okay.
And what struck me, I just want to mention something quickly. What struck me a lot hearing Scarlett talking is that I can really recognize myself in her with my own lip journey. So that makes this thing extra interesting and exciting.
Tell us a bit more about that. I do like that story of your first treatment. What was it that was similar to Scarlett's journey?
I had a little bit of the same problems that Scarlett described. I was self-conscious about my thin lips. In my case, both the upper and lower lip were very, very thin. And I also were very self-conscious about me smiling because both upper and lower lip tucked in. So it was more or less teeth like this. This is how I looked. And covering when laughing, loving to make people laugh, feeding from people's happiness, making them happy. That's also something that, just like Scarlett, that I like to do. And, you know, if you want to laugh a lot, you want to feel, you know, be proud of your smile, which I wasn't. So the hand covering was there as well. And she also mentioned she fixed her teeth. She wasn't completely happy with that either. And that is also a process that I've been going through as well. And also I thought it was beautiful hearing, I can say that my journey to work on my own lips as a teenager, it was life-changing for me, really, really life-changing. And I think that is the reason number one why I, as a 40-year-old woman, young woman, today are completely obsessed with lips. Some people would say get a life, but you know, I am so obsessed with lips. I just love them and I will never get tired of it.
I think it took me it was actually treating Miranda and seeing her response to it that really woke my eyes up to it, because I was very technical, I think quite masculine in the view of it's about the detail and the technical. And only when you live with someone who does it do you realize how much deeper it is for a woman. And if there are any men listening, like really pay attention. I'm sure the women get it already, but it's a different thing. That's why lips are such a big thing, because it's much more than just another part of the face.
Oh yes, lips are so important. It's, you know, for women, it's in the center. It's like sexuality. One of the most feminine feature we can have if we tweak a little bit. it really brings out the woman in you. Sexual attraction. There is so much more with lips than actually talking and eating. The functional aspects. It has a lot to do with emotions. We start using our lips the first thing we do when we get born. Looking for mommy's nipple to get food. So lips is a very, very important organ to, feed ourselves, to communicate with others, but there is so much more related to lips.
Yeah, feminine power, which is
Feminine
also why
power.
one of my favorite things is treating much older patients who are very much on the defensive, but you can put them almost back on the front foot easier than any other injection. I'd rather put 0.5 ml in someone's lip than do a 20 ml procedure on a 90-year-old.
I hear you on that one.
Okay. So our challenge is, how do we make Scarlett even more beautiful? What are your thoughts in terms of looking at the shape and structure of her lips? If we start with, well, I'd like to just hear what comes off the top of your mind first.
Absolutely. So I received some pictures and videos of Scarlett prior to this to assess, and without hearing what Scarlett thought about her own lips, I made a guess what she might think of her own lips, and I just assessed them and work with what I would do, more or less. And then after hearing Scarlett's story, you sent me these consultation video after I've done my injection plan, and it was quite it matched quite well what she was asking for. When I look at her from the front, like here, I think she is lower dominating, meaning the height of the lower lip is a little bit too dominating if you compare it to the upper lip. We do know about the golden ratio 1 to 1.618, which means the upper lip should be 1/3 in height and the lower lip should be 2/3 in height. Something that I really want to talk about regarding the golden ratio, that is studied on the Caucasian population only. What about the other beautiful ethnicities we have around the world? Amongst the Black population, it's not common to have a 1 to 1.618 ratio. It's much more common to have a 1-to-1. Same with Asian population, South American population, etc., etc. So also when I look at Scarlett ethnicity, she could really, really benefit to create a little bit more height. And as she says herself, some 3D projection, especially of her upper lip, because I really now, when we have her in balance here, I agree with her that, I love prominent noses. I really do. It's something about empowerment to have a solid nose. So I'm in love with that. Seeing that Scarlett has a beautiful prominent nose that is projecting a bit, I think that definitely we can improve her balance in profile by not even create more height. That's more for the frontal view, but from the profile view, a little bit more 3D projection. So it will look more softer and balanced. And often when you do this treatment in profile, if the patient is self-conscious about their nose, if we do that, they can look more harmonized and balanced in profile, and the nose looks suddenly smaller because it's just harmony. So that was something that I really thought, more height, more projection of her upper lip. Also, I noticed the gummy smile, and gummy smile doesn't bother all. If it doesn't bother them, that's wonderful. But Scarlett mentioned that it's bothering her a little bit. So there are some tricks we could do there, either with the toxin or even filler in the piriform or nasolabial can also help. Also by adding volume close to the wet-dry border in the upper lip can also help, camouflaging a little bit of gum. And then also with my technique that we're going to come through later or soon it's not only projecting the lip in profile. So what happens is you get more like an aversion and more red lip show, and also when they smile. So I do believe that we will be able to really, really come close to what Scarlett are wanting. I can also see on her upper lip that her central tubicle is projecting, and then right lateral to the central tubicle, she is a little bit flat, and then the lateral tubicle comes. So there is some flatness in between the central and the lateral tubicles. So I would love to create a more nice transition between the tubicles, so she gets more like an even 3D projection rather than it sticking out in the center, going like an inversion next to that projection, and then the lateral tubicle come out more projected. So I work a lot of these smooth transitions from the medial part of the lip to the lateral to create a nice transition along the way. I heard her mentioning her lower lip, the lateral part, the corners. I do believe many people have a thicker white roll here that doesn't have pigment on it. So often they feel like they are more pink and fuller in the center, and because they have more lack of red pigment in the corners, they feel that they are quite narrow. But exactly where you are pointing now with a hand along the white roll in the lateral part of the lower lip, often I'm careful injecting too much here because suddenly the lip can take a downward shape. So you get a more squared lip shape in the lower lip, and that is more a masculine feature. So I do like to keep it quite neat, not too heavy in the corners when I treat female lips. My personal opinion, I like more that diamond shape of the lip where you have the vertical height within the medial canthus line and then let the height fade out laterally. And I always try to match the upper with the lower corner so they don't get upper heavy or too much lower heavy. A nice transition, but I do like the lower lateral corner to be a couple of millimeters more height than the upper lateral corner. Like you said, look at her filtral columns, beautifully defined, beautiful definition. She has a very prominent, beautiful white roll. So today, and like always in my world, I always stay below the white roll. So we're not going to give her any unnatural or thick borders. We want it to look very natural and neat. When it comes to her tissue type, I would say she is somewhere in the middle of the scale. She doesn't have very loose tissue filled with a lot of empty pockets and compartments. She doesn't even have very tight, firm tissue. So she's somewhere in the middle of the scale, which I see the majority of the patients out there are somewhere in the middle of the scale regarding tissue between loose and firm, especially in this age range around the 30s and 40s.
Great. So the next part is, now that we understood that, because that's a great description of all the key components. Symmetry was the last thing that it often comes up, is just this, I don't know if you noticed.
Yes, so I can see on her left side, that means our right side, she has slightly more height of her upper lip, exactly, than on that side. That side is lower, and the other side is slightly higher. Also, her left side, our right, is more curved, rounded, while her right side, our left side, is more straight on the border. So this is like teeny small asymmetries. Also in her lower lip, I mean, it's so little, I wouldn't even call it an asymmetry, to be very honest. I think from any eye, even on a picture like this, I would say her lower lip is quite symmetrical.
Yeah, I think it's important that someone told me years ago that if you're too symmetrical, it actually makes you look slightly sinister, because our brains are not used to complete perfection, like CGI. And there
Exactly.
was apparently BMW had made a 7 Series in the 80s that was so sinister in the rear view mirror that the one thing that what they did to make it less scary is they made one of the wings asymmetrical, and apparently it made it less scary to see in your rear view mirror. Always stuck in my mind. So a little bit of asymmetry is not a bad thing. And I would agree with you. I would just call this being human. It's not really
You can also see her left filtral column. It's a little bit more thicker than her right filtral column. Also a teeny tiny asymmetry. Yeah.
Right.
Another thing that I could assess when it comes to creating a more feminine feature, I often look at, the lower face in particular, especially the chin. So you can see she's quite flat in the middle part of her chin, making the chin a little bit more square shaped. So if she were open to it, if she brought it up on the consultation, I would inject a little bit in the center of the point of the chin, just to make it a little bit more rounder. To soften it up, it would make the lower part of her face look less masculine, or slightly more feminine, I could rather say.
So she did bring it up just as we were waiting, and she is keen to soften this little dimple. So that will be an additional benefit we can do for her today. What I love in terms of, often when I'm looking at chins, it's quite useful to see if it's a good reflection of the lips, because if you see, it basically follows the contour of the lip, and it's a projection almost of the lip. And if there's something that's slightly different, then that's an easy way to beautify. And it's making the whole structure self-referential. That's kind of what the golden ratio tries to hint at, is that we're trying to make changes that are consistent with what's already there, which is a good way of deciding that. And I think the chin is an excellent observation of yours. That would be great.
Can you hear the church bells through my AirPods?
No.
Oh, okay. The church is playing for us now. You have God with you today, Tim, when I'm going to direct you. I don't think you need it, though. Yeah.
As long as it's not funeral bells, yeah.
No funeral bell.
Okay. So this is moving on to the injection plan. This is our suggested plan. Now, what I loved about the first live we ever did together is you said that your plan sometimes changes while you're injecting. And I've always referenced that because I always felt like maybe I was missing something, because mine always changes as well. And some people, like when you see Raj inject, he just seems to just deliver this fantastic plan as stated. Whereas I often change decisions as I'm going through. So this is only a prototype, so to speak. And it may not be exactly this as we go through it, which is worth saying. But I'm interested in kind of maybe breaking down these injections and hearing from you what the purpose, certainly of each color injection is. In your mind, what is actually happening in the tissue? Because one of the things I noticed as we were piecing this together is that you can see the depth, although they look like they're in the same place. We're actually millimeters slightly deeper with these certain injections than others, and I think that's really relevant to understand it. If I can capture it on the screen, do it that way. So look how these some injections you reference as being a couple of millimeters deeper.
Yeah.
So this is quite a useful thing to understand. Why are these green injections slightly more anterior, and how is that benefiting us in terms of pursuing the aesthetic goal?
So the green injections, they are in a very superficial layer. That's what I do my vertical injections through, that layer often. The goal with these injections, the vertical greens, would be to create more height. That's why I keep it only to 4 per side, because I want to reach the medial canthus line of the eye. That's where I want to create the most of the height of the upper lip. The more superficial you are, so I enter below the white roll. I take my bevel down to the wet-dry junction without piercing through the fascia in the wet-dry junction. So I'm below that part. And I do a slowly retrograde injection all the way out until I leave a drop of the actual filler on the tissue. And the reason why you get the height in this specific superficial layer, you create support under the white roll. The white roll works as a structural adhesion, and you create support in the fascia below the wet-dry junction. So just like a fence holding up the tissue, it will give you height without much projection. So that is the thing with the vertical injections, just like you see beautifully there.
So one of the things that I came across was when you look at the histology of the lip, you can see the connective tissue getting denser as you become more superficial. And I think this is one of the key things I've taken from your description of it, is this idea that essentially there's more traction in that tissue, so that you can actually create support that elevates. But if you go too deep, it's more about volumizing.
Exactly.
And we're talking like 2 millimeters. It's not, to the untrained eye, they look exactly the same, but one is more likely to create roundness and one is more likely to create vertical height.
Yes. If you want to create roundness, like the other color of the lines that I draw, then I dig slightly deeper. That allows me to inject also more product per line while injecting, without the filler being visible on the surface. So the first green lines for the fences, I'm in a very superficial layer. So you can't be too heavy-handed or press too hard on the plunger. So thin, delicate threads. You see the purple ones, that's more for 3D projection and volumizing. So I dig myself under the fences and usually have a more horizontal approach working from the side. And also it can help sometimes. And this is such an easy trick that many out there are not aware of. And when I show them, they're like, oh, why haven't I thought about that? And it can also help if you get a little bit of a dent. An indentation in areas happens all the time when we work with the soft tissue that have connective tissue to the surface, that we get these indentations. If you really want to pull out more projection, make a little bolus there a little bit deeper, and then you do that magic squeeze. You protect the injection points that you went through when you did the vertical ones. Then you take your thumb under, and then you give the lip a squeeze towards the surface. Because we do have like micro channels in the soft tissue. So if you give that squeeze towards the surface, often I don't hear a pop sound, but I get a pop, like a more of a 3D projection. So that is a good tip to do. Go slightly deeper, inject a little bit more per line, and then do that squeeze. I often get a beautiful 3D projection of the lip.
The squeeze is such a good tip. I think it often, when it all comes together, is when you do the right thing with your supporting hand.
Yes. And these little crazy little 3 ones that comes from the GK point, those ones, yes. I wanted to do that vertical fan right next to the GK point. That was again to try to create a better transition between the central and the lateral tubercles, because she has a little bit of an indentation on both sides, a little bit flatter. So by going in again superficial, doing a fan like that, you can also try to squeeze if it doesn't want to pop out properly. It's just to get that transition over to the lateral tubercle.
Tell us a little bit about the total volume that you're placing in these green injections when it's a retrograde linear thread. Roughly how much?
So for the fences, I would say pretend that you're using a BD syringe, because it's easier to think of the amount. One fence would be approximately 0.03 milliliters. So like 3 lines of a BD syringe. These vertical fans that I have next to the central tubercle would even be thinner. because I would like to do them very, very superficial, so it doesn't show any bubble on the surface. So maybe 0.02 milliliter per line there. When it comes to the deeper ones, I would like to say that one fan, like you see the purple, it has looked like Julie Bass Kaplan would say, a chicken feet. I would say all these 3 lines is close to 0.1. So then you need to have a little bit more pressure on the plunger, and you do that little squeeze, and that will give you more 3D projection. And you see I have a little green line also along the border more laterally there. And sometimes, you know, when I do the fences, I get the height, I get the definition at the same time. Because when I pull the product with me all the way out, I enter through the vermilion border below the white roll, always in the pink portion of the lip. And when I slowly do my retrograde injection, the filler have time to spread in both directions through that empty tube that the vermilion border is. So you get the definition at the same time. Sometimes that filler can spread all the way down to the commissure, but sometimes you get definition only to the medial canthus line, and then the definition is flatter in the corner. So sometimes I go in, I would like to say the old traditional way, just finding the vermilion tube and do a very careful straight, just to again create a nice transition of the definition all the way to the corner. That's why I put that green line there. It might not be necessary, but it might be.
This is great to be able to see. You can see the different depths and the different volumes
Yes.
so clearly. That's something I hadn't actually, until you talked us through it, I hadn't spotted this. I'm sure my Jake, who does our 3D, spotted it because he did it, but that's really cool.
He did, yeah.
See that.
And for the lower lip, you see, I haven't even done any verticals there because I don't want to create more height of her lower lip because it's already dominating. So for her lower lip, I would only do what I call like a hydration treatment, where I fan a little bit horizontally just to give the lip a little bit more plump and that hydrated look. Often if we ignore one lip and only treat the upper, we don't do anything with the lower, you can see a difference in the texture of the lip after the healing process. There is something with hyaluronic acid. It does attract fluid in the tissue. And so you get a little bit of a smoother, more hydrated look of the lip. So if you ignore one lip, they can look a little bit different in texture.
Do you think it can ever affect the color, like a more persistent slight redness into the vermilion longer term?
100%. I see that all the time. And I also have pictures showing me that. But with that said, the theory, I work very close with my dear friend and colleague, Sebastian Cotofana. I'm also involved in one of his latest lip studies that will be published soon, I hope. I'm very excited about that. When it comes to the color improvement that I really get a lot, I sent him lots of pictures and please explain this to me. The theory, we don't have proof, there is no studies, but if you are using a non-hydrophilic filler, meaning a filler that doesn't attract excess fluid, and you inject in a specific layer of the lip, the theory is that you're pushing the microcirculation, the capillaries closer to the surface. So there you can get a little bit more deeper pink color of the lips. If you use hydrophilic fillers, I don't think very small amounts matters. But if you use a full syringe or, you know, a full lip treatment with, or even repeated lip treatments with hydrophilic fillers, I get more the opposite effect, a more diluted pink color, a more pale, artificial, diluted color. So yes, I think that is the way to go to stay away from you know, big amounts of hydrophilic fillers in lips. Interesting.
So the next thing which we can't go without missing is safety. And I know when I spoke to you last time that you currently have never had a vascular occlusion.
That's correct.
This is, I've had one vascular occlusion, which was on the lower lip, but I'm interested, I want to make the point that we've spent a long time trying to get this artery to match what the textbooks say about the depth. And you can see that there isn't a lot of room if you don't have high resolution to your anatomy. So it's about 3 to 4 millimeters at points that the artery will be to some of these injections. Now, I will say, although I say there isn't a lot of room, that is a lot of room when you're actually aware of it. It doesn't feel like you're close. You know, your needle is less than 0.1 of a millimeter, I think, or 0.2 of a millimeter, something like that. So we have a lot of space if we know the thickness of our needle and where this artery is. And I think this is why you can enjoy a relatively low risk in terms of vascular occlusion experience with injecting in these planes that you've so well described, because all of them are relatively in the anterior part of this lip. And whatever debates we have in this industry, it often comes from observation of the same angle, but a completely different position of the needle. So you end up with a vertical injection that's running right through where these arteries are, which you rightfully should be challenged. But this is not where we are going to be injecting.
No, that's very true. And when it comes to vascular occlusions, I mean, I'm super humble about it. I know it will happen to me at some point. Just recognizing it and treat it as soon as possible and follow up the patient very tight and make him or her feel very safe during the process is, I mean, most important. So I'm super humble about that. It can happen to anyone. And also the pattern of the labial arteries. There is a big variation out there. So even what the anatomy book says, we can always bump into someone. Less than 1% can have the labial artery in front of the muscle. So it's about also bad luck, I guess. But I always localize the labial arteries before I start injecting. I look at them, I feel them, I have a good idea where they run, and then I can, in that way, avoid injecting into them as much as possible. But we are never 100% safe. So I haven't had one yet, nor have any of my delegates that have attended my training throughout my career. We have never had a case of vascular occlusion there either. So I think the statistics there, I mean, I've been injecting over 20,000 lips or around there. I would say it's, if you really do this very detailed, like we will see today, I would say it's quite a low risk technique, yes.
So something else to help all of those who've tuned in is if you hear, there's so many ways of describing where these arteries are, and it's often on very low resolution models. Our resolution as injectors is actually higher than most of the papers that describe the anatomy, because they will say things like the artery is in the vermilion border, or the artery is in the wet-dry border. And we know that it's very close, but when you're, and it's a bit like saying the artery is in your head or the artery is in Manchester. Like, it's not wrong. It's not wrong. You're technically correct, but it's not high enough resolution. So we need to be thinking in terms of resolution and the fact that we've usually got 3 to 4 millimeters, if not more. And then also what Julie says is a fantastic additional tip, which is spend some time looking before you inject, because I was so impressed when you told me that you thought it was about, I think you said 1 or 2 in 50. And then I looked up the data, and it was exactly that. It was almost, which is an amazing kind of experience that matches people who've actually spent time counting it. So we'll check on Scarlett that that this artery is not in the place where we wouldn't want it, and then you're probably quite close to what the papers tell us. Yeah. But we always inject as if there's a room with leaving room for error, of course.
Yeah.
Okay. Okay, so the final section will probably be quite a short section, but in terms of materials and tools, what are the thoughts that go through your mind in terms of choosing the right filler and then deciding whether to use a needle or a cannula? Can you talk to us a little bit around filler properties that you value in different cases?
Absolutely, I would love to. So when it comes to which filler I would like to use in one specific lips, I mainly look at two things. One thing is the patient's natural lip tissue. I diagnosed the lip tissue and I know the rheology very well in the products I'm using. I followed even, after the lips are healed. In the first few years of my career, I always brought the patients back, even if they text me, no, all is good. It's fine. I'm super happy. Yeah, I bet you are. No, just kidding. But you have to come back because I want to learn from this experience. I want to see them, how they look when they are healed, because I only saw them immediately after, and that can look quite different to when they really settle. So I said, come see, 2 to 4 weeks after, they had to come and show. I had to touch, I had to feel, they had to smile. In that way, you really, really learn how different filler, the rheology, how they behave in different types of tissue, also not immediately, but also over time. So that I learned a lot from. So if we talk about the tissue type, lips is one of the most animated area in our face, right? Eyelids and lips. So therefore, I like to choose a filler that have some kind of extrain or flexibility that moved with the tissue in animation for natural expression. I like them to be tissue integrative, especially when I work more in the vermilion or in the tubicles. I can use 2 different types of products, one low G prime with high tissue integration into what we can call the body of the lip for volumization treatment. And then I can switch to a high G prime, low tissue integrative product to work around the border. Often the tissue is a little bit firmer along the border, and then they can get a little bit looser and baggy further down in the tissue. So flexible filler for natural expression, tissue integrative to minimize the risks of lumps and bumps and encapsulations over time. The other thing I look at before I choose my product would, of course, be the patient's story, the indication, what their lip goals are. If they say, I want height, I want as much definition as possible, well, then I need to think, which product. So it's the tissue and the patient's wishes that comes together that helps me decide which product. And I touched the topic before, and I haven't touched scarlet tissue, but I'm starting to become quite well just by looking at it. And I also looked at her lips when she was speaking during the consultation, the beautiful consultation. So she is somewhere in the middle of the scale, not very loose, not very firm. And often I choose a medium G prime product with tissue integration and also flexibility in that case. So we're going to use that today, product.
Are there any, because one of the biggest battles clinicians face is this whole looks okay on the day and then swells. Are there any products that you've found least likely to cause that problem? I mean, I don't know if this isn't, by the way, a sponsored video, so this is not a company opinion. I'm just curious.
True. That's very true. Well, I mean, I can sometimes talk bad about my own product portfolio. So, I don't really care about brands and stuff like that. I found a portfolio that I really like to work with, and it works well, and I know it very well. But what was the question now again? I got a little bit.
I'm just wondering whether you think there's a difference with products. I think that's the key question, because there are a lot of people who will say it's all bad injection if you get migration, and some people will say it's all product. And I'm wondering particularly with migration, which is one of our patients' fears, what is it that you've noticed is is the factor when you've met patients with migration, and what their history was?
I think it's both. It can be product related and technique related, sometimes a combination of both. Again, these hydrophilic fillers, without mentioning any brand names, or can we do that? Or maybe not.
I don't mind.
You don't mind?
I don't. Well, it's my experience. My experience is, I can say you can say what your experience is. You may be wrong, but.
Or no?
I don't. Yeah. Yeah. But, well, I'll say from my experience, for example, it's not an like I use mainly the Allergan range, and I can see a strong difference between Juvenom Ultra 3 and Juvenom Vololift in terms of tissue integration and swelling. And over like a year later, I can perceive a difference that with Juvenom Ultra 3, you will attract more moisture, which isn't always a bad thing. Like, it can be useful in the nasolabial fold, which just means it lasts for ages, but it's probably not a good thing if you want to create a well-defined lip over a long period of time.
It's
So
true.
I'm
Mm.
I'm
Yeah.
happy to put that on record. I don't think that's negative for any drug company reps who bought a ticket.
No, that's really true. I see that, and I agree with you. And these hydrophilic fillers, we also have one within the Restylane portfolio. In Europe, we call it Restylane Volume or Volime, someone pronounce it. And in the States, it's called Contour now. Big particle sizes. It attracts a lot of water. Some people likes injecting these in lips, and I don't see a problem with that if you do small amounts of it. And I don't see a problem injecting small amounts of any hydrophilic fillers in lips. It's more when you add too much, you have this issue. But definitely stay within the more or less closed compartment of the lip, which we are going to do today. There is an anatomical limit how much filler we can squeeze into that space in each and every lip to prevent filler migration. So if you overfill, create high pressure in that closed compartment, I mean these thin fascias, let's say the midline fascia that separates the left and the right component of the lip, they are not made of steel. So if we create high pressure in this closed compartment, in addition to all the muscle movement going on in the lips, of course, these delicate structure can burst or, get destroyed, and the filler can start migrate. So overfilling using a hydrophilic filler, even if you are in the closed compartment of the lip, can cause issues over time, in my opinion.
I also think, given that we know sometimes these fillers are lasting 12 years, that it's not even necessarily bad injection. It could just be the nature of putting something there and waiting 12 years. So what I've started to do is consent all my patients for the possibility, because I think it's better that we don't store up a bank of patients who aren't expecting something. I think it'll be a minority, but I know patients I treated many years ago who never had their lips treated, 4 or 5 years have gone by, and they've come back to see me, and I can still see this filler there. So this is not something that, I don't think we know what happens to filler over 12 years, even with the best injection at a low volume. And it's better that your patients are consented for the possibility. It's easily solvable, of course, but that's my current approach, is to just say that it's a possibility, regardless. It's maybe just the nature of a semi, it's not really a solid structure. It could move with repetitive movement over a decade.
Sure.
But much less likely to do so if you use a good product in the right domain, in the right part of the lip, which is what we're going to do.
Yes.
So what about your thoughts on cannula? Would you ever use a cannula, or when do you use a cannula? What are the downsides from your perspective?
I would use a cannula. I do it sometimes, especially if I have a more mature patients, maybe 70 years and up, maybe very thin, flat lips, inverted. So from a front view, you see more or less this. Nothing. So you have no eversion, no red lip show. So also as we age, we get more and more vertical, right? Because of the muscle atrophy, the bone resorption, in the maxilla, the dental status change over time. Many factors, the skin, the elastin, collagen reduction and everything, we get more vertical. And also, I believe as we age, then the positioning of the labial artery can also fall down a little bit, so it can change. So for that reason, I often use a cannula on my first session on these lips, mainly for safety reasons, but I don't really see any idea of doing vertical injections when they don't even have any red lip show in the front. So I would like to build up a little bit of volume and aversion first. And I do believe sliding in gently with a cannula, working above the wet dry, the fascia in the wet dry junction, try to get a little bit more red lip show, aversion and projection in the first treatment. Then I can take her back when he or she is healed and do a few vertical struts to get that height a little bit in the center. So that would be one of the reasons I would use a cannula. Why I don't use cannula that very often. Oh, I might have some people that might scream at me now, but I feel I have less precision working with a cannula. I can't do these millimeter little tweaks like I feel like I can do with a needle. I struggle finding that extremely superficial layer I want to be with with a cannula. And this is the point I'm coming to. And I don't believe there are any studies made, or I'm not saying this is the truth, but I have heard many colleagues of mine also saying, I experienced the same. And I also, depending on how many treatments have been done in the past, and also what kind of technique and how gentle or not gentle the injector were. But I had a few cases where I had patients with, I got a cramp, sorry. Oh my goodness. All right, I'm stretching out now. Here we go. Okay. Oh my goodness. I get a cramp in the middle of our webinar. A thigh cramp. Okay, it's letting go now. Oh yeah, here we go. So yes, and repeated times over time, lots of cannula. I have experienced when I then go in there with a brand new, fresh, sharp needle, I get a little bit of this, the fibrotic tissue. That maybe is not just related to being a cannula user. It might be depending on how much back and forth subcision they have done with a cannula. So it can be also depending on technique and the injector as well. But I see that more often when they use thick needles or cannulas in lip. I feel more of that fibrotic tissue over time. That's why my favorite is to work with a thin wall 30 gauge needle for lips. In some cases, BD syringe if they have very thin lips. So it's hard to get precision with a 1/2 inch needle.
Yeah, so there's a couple of great points on that. Firstly, I 100% agree. And if you think about the nature of a cannula, it's designed to be safer, which means it's deflected by connective tissue. So you cannot get into the same plane as you can with a needle as easily because it's deflected by connective tissue. That's why they're safer. So there is always a downside. Good, very good first pass. And then I love this approach of make some room, cause a little bit of elevation, and then maybe use a needle next time. That's a clever way of doing it. And I also wanted to just reflect again on this, how the lip anatomy changes with perspective to arteries and safety over time, because that's another really important subtle thing which makes these discussions around what is the safety technique very blurry. Because someone once did send me a paper saying it was absolute, like, concrete evidence that a vertical injection was dangerous, and it was based on a cadaver study. You know, they're all average age of 87. You are forced to do a really different angle if you've got basically no lip. If you're trying to do a vertical lip, you basically go into the white lip where the artery is, and of course that's more dangerous. But you wouldn't use that injection on a real patient in a million years unless you haven't thought through what you're doing. So aging and anatomy makes a difference to when these techniques are applied, which is, you know, today we have Scarlett, who's a younger patient with enough room to do some vertical injections, but it's not the same. It wouldn't be fair to compare her with a 90-year-old doing the same thing in terms of where the artery is. They change a lot.
It does.
Okay, crunch time for the procedure, I think.
Yay!
Okay, I'm going to pop some gloves on.
Cool. This is the fun part. This is where I put my Swedish snus in. I'm gonna enjoy this.
Scarlett has got amazing dress sense. First
Oh,
thing I noticed.
look at her lips and cigarettes. That's fantastic. Well, maybe not cigarettes, but lips.
I love looking at my patients' clothes and the things that they wear because they're giving clues about what they want to express. You know,
I
this is
know.
a cheeky jumper. She's funny. She jokes. She told us in the consultation. We already knew it.
We knew
But you
it.
can tell because
Yeah.
people express themselves all the time.
Absolutely. That is so funny. Well done, Scarlett. Good choice.
Okay, yeah. Let's see if we can using Julie's technique. See if we can find any evidence of a blood vessel. Be worth doing.
Yes.
So tell us how you normally would do it. Would you?
Exactly. Fold it up so you get a nice view of the wet-dry junction and approximately a centimeter of the wet mucosa. And then I stare at it and I look for pulsations. The eye catches movement very easily, especially if you have good lighting that reflects through on the wet mucosa, if you see any movement close to the wet-dry border. If something bulges out, it can be a gland, it can be soft tissue, but it can also be an artery. So stare at it for a while and see if it pumps or not. Twerks, I say, twerking. If I can't see anything, then you just gently tuck your index finger inside her lip, Tim, and you try to palpate the pulsations with your index fingers. I palpate close to the wet dry, and then I dig myself higher up. Then I usually find it there when approximately 80% of the cases, we can expect the labial artery to be in the height of the vermilion border, deep behind the orbicularis oris muscle.
We've got an amazing view on the screen, so it's actually better for me to see it there than in reality.
Yeah, it's great, actually.
I can't. Stop me if you can see any pulsation. I'm not seeing it.
No, I can't see anything.
Okay.
And then
lower lip?
the same thing. Usually easier to fold down the lower lip.
That looks fine to me.
Yeah.
Okay.
And also an important thing that if the patient have 4 dye spots on their his or her lips prior to the treatment, I mention that to them and I tell them what it is and that some patient might see those 4 dye spots a little bit more visible after a lip treatment, because when you expand the tissue, you can push those glands further, towards the surface. So it's something that I mention.
Let's have a look at them on the macro lens again. They're worth seeing. So
Yes.
these tiny little sebaceous glands, and a lot of people have not noticed that they've got them until they have a procedure, and then they look more closely, or perhaps it's during the stage of swelling, and it can create anxiety if you've never mentioned it. But
Yes,
if you mention
exactly.
it, you don't have any of those problems. So that's another tip you only get from experience, is to point it out before the procedure.
Yes.
So just so you know, Scarlett, that's just a tiny little white dot, which have you ever noticed? Yeah, she's noticed them, so that means we were already okay, but many patients have not noticed them yet.
Mm-hmm.
Thank you. So I have Mary assisting me in the corner. I'm not actually used to an assistant, so I hope I don't forget that you're, just prod me if you think you can help.
So what product are you using, Tim? Are you going to share that with us?
So this is Restylane Kiss, and this is actually the first time I've used it, but I'm here to learn. So I'm keen to see what it's like. I've got many more boxes than we'll need, so I don't mind if I waste a little bit. Feels similar extrusion force to what I'm used to. It's a bit, you said it would be a bit firmer.
Yeah.
It is, yeah. Okay, so I'm ready. Tell me, what should we do first?
Start at the GK point. Have a more straight down approach. We do the straight ones first, and then we end with that little fan. So the GK point, yes. And then you stay below the white roll. You enter in the pink portion through the vermilion border.
Yeah, I'm not going to inject. Just want to hear your description first. So pink portion.
Yeah,
Just
you
there?
can make a drop there since you don't mind spilling product. You can make a mark. That's where I would enter. Yes, there.
Can we look at the macro lens again? I think it's a better view. Let me do it on this side.
Yes, exactly. Her white roll is so pronounced. So sometimes it can be difficult to see where the white roll runs, but her, it's very easy. So always stay below the white roll. So that will be my first enter point. And when I enter, I can have a little bit of a more perpendicular angle just when I put my bevel in. And as long as my bevel is in, that's when I angle my syringe like this and slide in a very nice and superficial depth. So I want, yeah.
What are you doing with your supporting hand to, because my inclination is
Like that,
yeah.
yes. You flip up a bit so you can see what you're doing.
So this is creating a straighter area, a
Yeah.
straighter path. Yeah, okay.
Correct.
Do you ever put a little bend in the needle or do anything like this, or is this usually enough for you? I have room to do it, to be honest. I don't need to bend it, but
yeah, often I have a little, I fickle myself down in the tissue rather than just pew. So if the lip are already very 3D projected and rounded, I go in and I try to fickle myself. So I'm staying a little bit in the same layer all the way down.
that's another great tip. So it's not just about the destination, it's also about the journey.
The journey, exactly.
Okay. So I'm entering just on the pink. I was sliding down. How deep am I going before I stop?
I mean, you go to there, yes, that would be a great stop.
So that's kind
Right
of
above the wet dry
yeah,
junction.
like a couple of millimeters from the wet dry.
Yeah.
And then on the way out, I'm doing 0.03. So that's half of in fact, this syringe only has 0.1s, is that right? 0.8, yeah.
Yeah, 0.1. So you won't see much happening there, unfortunately, with the bigger syringes. So it's a lot about feeling.
So what about the angle of the bevel? Are we bevel pointing down?
I am bevel up. I don't know why, and many says it doesn't matter because the filler comes out more or less straight anyway. But since I am sometimes in such a superficial layer of the lip, I just like to have the bevel up for some strange reason.
A little bit more anesthetic. Okay, I'm going to follow you because that's what I'm here to do.
Yeah.
I think I probably would be more up anyway.
Mhm.
But sometimes that's also very nice of you to not invent a reason, because I often think people invent a reason.
Just to have a reason. Yeah, I hear you.
I call those the idiosyncratic habits. You may discover in 6 months' time or a year's time that it's better to do something different, and then you change. But it's better as a trainer to admit that sometimes we just do things because that's how we do them.
Very true. I see you use numbing cream. I use dental or mucosa block with lidocaine when I do lips. But I mean, there is nothing right, there is nothing wrong. I did numbing cream before, but after implementing more and more mucosal lidocaine blocks, I prefer that method.
Oh, that's interesting. So I thought that was a relatively new thing for you to switch over.
It's quite new, yes.
Yeah. So I started out with blocking all the nerves, not a gingival block like I've seen you do, but and that was awful because patients were like dribbling and.
Oh yeah, that's horrible.
Yeah, so that's why I stopped doing it and then went back to just using numbing cream, and that seems to work for most patients. And Scarlett looks very laid back, so.
She does. She can have a cigarette after there from her sweater.
Having multiple as you go. Okay, right. So I think I'm clear on what to do. We're entering the GK point. We're entering the pink part of the lip. We're sliding down, carefully following the path, the contour of the lip.
Yep.
We're stopping 2 to 3 millimeters from the wet dry border.
Correct.
And then we're going to slowly inject. I'll do a little depth check and then slowly drop about 0.3 mils on the way out.
Perfect.
Okay. How does this depth look to you?
Can I get a more straightforward angle? From the
Something-
camera?
Scarlett?
Oh, there we go. That looks great. So I always lift up my syringe like Tim does there to check my depth, and I want thin tissue to cover the needle. I want that elevation of the tissue and that specific blanching. If you can see the gray color of the needle through the tissue when you lift up the syringe, you are too superficial and you will get that filler bubbles on the surface. If you lift up and you have too much heavy tissue, not that tissue elevation, and no blanching, you are then in a volumization layer, slightly too deep. It looks great, Tim. So you can do it at slowly retrograde. And then if you try one and you get a lot of these bubbles on the surface, then the next one you can go slightly deeper as a test. But with this product here, if you get a visible bubble on the surface, I do what I call the scratch molding, and it just blends beautifully in. And here it's important to pull the product with you all the way out, so you get the definition that fills that vermilion tube or tunnel. Great job, Tim.
So would you be doing molding now, or do you wait?
Usually I wait. I do my 4 fences and then I do a little bit of the scratchy if needed.
I've got to say, I have never seen my procedure so close up, so it's a and we're not doing any clever stuff to reduce bruising. I know I've heard stories of people giving patients steroids and all sorts of things. I don't even know if they're true, but this is just like it would be in your clinic. So if we get
Yeah.
bleeding, we can hold it.
This is live stuff, no hocus pocus. And often when I do these very superficial injections, I get less bleeding. And when I dig slightly deeper, I can get a little bit more bleeding. But always when I say that, and the first thing I poke, very superficial, and it just pours out. So, I mean, anyone can be a bleeder. It's also depending on if they have taken medication, have alcohol the day before, etc., etc. Vitamin supplements, looking great, Tim. Beautiful. Nice and slow, especially at the end, so that tube vermilion border get nice and filled.
If I do one more, that'll be 4. Did we say 3 or 4?
You mean fences in total? Yeah, 4, I would say.
So I will say, for those of you who are worried about complications, 0.03 mils spread out over the entire anterior surface of the lip at such a superficial depth, like that's a very safe injection. The idea
Yes.
that you could block the labial artery from that is a very, very unlikely. And I think this is why you've enjoyed this low prevalence so far, because the best case I've seen has been about 1 in 6,000 chance of vascular occlusion. I'm sure you've done many more than 6,000
Yes.
lips.
I have, but I did poke one in an artery once in front of the muscle. But before I started working in this aesthetic field, I worked with the heart surgery patients for 13 years. And I put in a lot of vein catheters, draw lots of blood. So I have a good relationship with blood vessels and needles. I just have the feeling for it. And as soon as my bevel pokes through a vessel wall, it's just like often I can feel it. And I had that situation once where I exactly did what you're doing now from the GK point. And I put my bevel in there and I could feel, this feels familiar. And I just took the needle out and out came this pale artery blood. And then I touched, and this was a long time ago, I touched and I could feel her pulsations on the outside of the lip. That looks great, Tim.
So my habit is to go straight back and massage and feel afterwards.
Do it.
You're saying okay.
Yeah, and especially if I see little bubbles like that, I go straight there and mold it out.
It's so built into me that even when I'm training other people, I always want to grab the patient afterwards and feel them after they've injected, because I just don't know what they've done. About a lot of what I'm navigating around is what I feel.
Mm-hmm.
Okay.
If someone just tuned in when you said that sentence there, might thought you were thinking of something else, but we're still talking about lips and injectables here. And you like the feeling and touching your patients. It's looking good there. I can see now that the central tubercle have a much more nicer transition over to the beginning of the lateral tubercle. So I will continue now, 2 to 3 millimeter lateral to that injection point you have. I would do my next fence straight down.
So about there.
Yes, and continue until you reach the medial canthus line.
So
That
here
looks, yeah, that looks great, Tim.
to
Yeah.
there.
Yeah.
So let's have a new needle soon, actually.
Yeah, that's a good point also to mention. I also switch needles quite frequently if needed. As soon as they get blunt, I like to switch.
And you get the little bleed. Yes.
Mhm. And on that injection, you were a little bit too fast out at the end. I want the filler to spread in that vermilion tube.
Okay, so as I'm coming out, I'm injecting all the way up until the vermilion tubes get some as well, because that's
Yes.
an extra detail that I hadn't absorbed before.
Yes, that's great. Why don't you do another little fence there, medial to that one? And then you go extra slow at the end.
So this is actually, this is what I love about this type of thing, is you often get, as someone drifts off your way of injecting, it's so obvious to you,
Mhm.
but and it's a great way of just making these details more prominent. Okay,
Mhm.
so let's just rotate you slightly. Where are you suggesting?
Just medial, not lateral, medial to the poke you just did.
Was it there?
It was there. Yeah, give it a squeeze, some blood will come out and you will know. There you go.
So
Just
yeah.
medial. Yes, do one there and then you go extra slow at the very end. That's perfect. Great. And now slow out. Yes. Yes, there we go. Now I can see how that tube filled there. Perfect. You got it.
Right.
Now you can jump to lateral to that last one you did. You see she has a little bit of a deep crack there. Go under that one. Yep. Follow that one. Perfect, Tim. Looking great. And retrograde. Perfect. And nice and slow. There we go. Yes. Beautiful.
It feels good being trained again. It's been a long time.
Yeah, I was just about to ask, how does it feel to be a student again, Tim?
I love it.
Cool.
It's euphoric learning new stuff. It's one of the interesting things about being human is that when you suddenly, when you do new things, that you get a euphoric boost once you. I remember that first time staring at a biochemistry textbook and I didn't understand something, and then I did. I was like, wow, that's a pleasant feeling. Understanding, yeah. That was cool.
Cool.
Okay.
One more, maybe. Beautiful.
So I'm pulling back if I see the skin blanch when I'm going through. So I'm pulling back slightly from that.
Yes.
That I don't get. How are you doing, Scarlett? Okay.
Amazing, Scarlett.
You're doing so well, Scarlett. Perfect, perfect patient.
Okay. I will say, as when you're being trained, your brain is not doing the same thing as when you're actually injecting. And so I'm actually tracking much more what you're saying and the detail of each injection than I have where we've actually been. So if I'm obviously we're going to repeat the same on the other side, but I'm picturing maybe one across that crease. You tell me.
I think so. You don't have to go all the way from the border. You can start just where the crease starts, further down in the lip, just to smoothen it out vertically. Yes.
Okay.
Yes. Look at that. It's magic. It's gone. So I always do that. I haunt these vertical lines and go right under them. It really lifts them up and smoothen out the tissue nicely. So she has another crack there. Yep. That one.
Sorry.
Beautiful, Tim.
One more?
Yeah, one more. Yes. Well done. Now you can do your molding magic a bit, and then we can look if we want to do two between the GK points or not. Sometimes it's necessary, sometimes it's not, but we have to assess it in every case.
So this is an interesting injection because right when I first started injecting, someone taught me to do that. And then I think I had 2 or 3 cases where I actually felt like I lost some of the U shape of I was probably not selecting patients correctly, but it put me off doing that injection. So tell us a little bit about reasons why you wouldn't treat that middle section.
You're so right. So if they have a Cupid's bow, that they don't have a lot of space from the GK point down to the midline on both sides. So it's a very little short or not as pronounced and, Cupid's bow. Exactly what you said. Sometimes if you go in there and do an injection there and there, you can completely flatten out. So sometimes it's better to leave this place alone. So you get height from the GK points. The center part will follow up with the swelling immediately after. But when the swelling goes down, will get a more of depression in the center. So the Cupid's bow is more highlighted. Another thing with Cupid's bows, if they have a heart-shaped Cupid's bow and they would like them to be more pointy, more like the Swiss Alps, you think you should always go down from the GK point and straight up on both sides. Then you will get more pointy Cupid's bow. And if you do the V in between, you will get a pointy Cupid's bow if you have distance enough there. But if you have a patient that have these Swiss Alps and she wants more of a heart-shaped Cupid's bow, so instead of going directly 90-degree down from the GK, I go slightly lateral to the GK point. And instead of doing a straight line between the GK points, I do 2 micro fences. Do I have something to point with? Oh, I should have some makeup here. A brown one. So instead of doing those, I can do like 2. I have a very narrow one, so I just do 1. Fences like this.
Yeah.
So I just go halfway down diagonal and pull it up through the vermilion border again. That creates then a little bit more height in that area, so you can get more heart-shaped Cupid's bow.
So what do you think of Scarlett's?
I think, let me take my mustache away. I wouldn't touch it more, to be honest.
She's got beautiful definition. It's actually not, it's actually even more so in real life. So I agree with it as well.
I would leave it. Yes, I agree. So now it's more for the horizontal, little bit deeper horizontal fanning for the volumization, the 3D projection of the lip. And from my painting, I start so I can reach the GK point. I would enter, yes, measure with my needle, and I always enter in the middle of the lip, not too close to the vermilion border, not too close to the wet dry, because that it allows me to be able to fan with my needle in all directions, so I can reach every corner there. So that looks great, Tim.
So are we going to do, we're going to do 3, do you think, anticipate 3 injections?
Yes, anticipate 3 injections there.
Okay. And volume of each one?
I think that we don't want too much. So stay below 0.1 in total of these 3. Yeah.
Okay. So the other I'm interested because this entry point in the middle here, this is so that you can do more of the lip.
Yeah, correct.
With 1 point. Okay.
With 1 point.
And okay, so I'm going to enter about there. Agree?
Yes, I agree.
I mean, enter at the base of the needle.
I know, yeah. And now you're just thinking that you want to dig right behind the fences, which you do very well there. Great. Nice.
Okay, and then linear thread on the way out.
Yes. Great. Then you can angle it more straight. Again, fickle yourself behind the fences. Great. And the last one close to the wet dry, usually I do a little bit thinner and I make sure I'm superficial. Yes, good. Great. I'm gonna let you do your molding.
So I'm feeling and molding at the same time. I'm not just mashing it down. I'm getting sensory feedback as I'm doing it. Often I see people when they just start and it's like they're squeezing without feeling. I'm gently smoothing it. Smooth it, don't move it, I always say.
Exactly. Well said. Smooth it, don't move it. So now we want to connect this, we could do the other side. I feel like I have more control over the end result if I do the fences on one side and I do the fences on the other, then I do this. So I jump back and forth to, process the whole process to reach the goal. Because sometimes if you finish one side and then you do the other, you have forgotten small details you did during the way.
Agreed?
Yeah. Wow.
I'm starting to get a bit of resistance from this needle.
I see you aspirating once in a while. That's good.
It's so built into me. Sometimes I do it without even.
Yeah, why not? Doesn't harm or hurt anyone.
And you can do it multiple times if you like.
Mhm.
A lot of my thing with complications is you've got to do what you've got to do so that you can practice. And
Mhm.
whatever brings you peace of mind, do it all.
I agree.
And the rest is very academic. But one thing I don't like is people not doing procedures because they're afraid of complications, because I think those people are probably the people who should be doing most of the procedures because they're naturally cautious.
Yeah. Do you think I should start doing noses again?
If
That's
you're
scary.
afraid of doing them, then
Yeah,
yes,
I'm super scared.
because otherwise you're leaving them in the hands of the people who are not afraid.
No, I refer them to the nose experts out there. But I don't have a high demand of noses, so I don't feel like I never get that good at it. And it's such a high risk area, but maybe one day, Tim, we can do this and you teach me how to do noses.
Well, I'm going to make a 55-minute nose job training instead of the 5-minute, because I think that's what you need. You need to take 55 minutes at least, and then all the people who are afraid, once you break it down, it's not that scary, I think.
Okay, count me in. All right, so now we want to connect this to the commissures. So I enter more or less right in front of the commissure and do an fanning there as well until I see, yes, until you have a nice transition.
Okay,
You can, yes.
How many injections?
I would say
again?
two or three. Yeah, I try to not make too much in the corners, so to the height fade down a little bit. So maybe 2.
Okay, and a total volume of?
Yeah, very little.
0.05?
0.05, yes. That sounds like a great amount.
Agree with this entry point?
Yeah, perfect.
That's okay?
That's perfect. And here I have a trick when you work with corners. Work first close to the wet dry border, because if you start closer to the vermilion border, the lip can actually fold inwards as you work. But if you start at the wet dry and then work yourself up, you have a higher chance of getting more eversion and red lip show in the corners.
That's a great tip. That's one of the most frustrating things, is trying to get that lateral eversion.
Oh yeah, the corners can drive you crazy. And when one corner acts different than the other corner, it's also quite frustrating sometimes. So can you see there that, and this was her natural anatomy that we talked about when we did the assessment, that she's rounder on one side of her upper lip. I'm talking about the border, and flatter on her right side of the lip. So here I can see that flat portion still. So I would do a supportive horizontal injection sub-vermilion and try to do a little bit of a curve with your needle that can give her the same rounded shape there. So you can enter a little bit, yes, perfect. Now I think where I'm missing, I wish I could point with my pointer so you could see where I mean. So it's from the GK point and 1 centimeter lateral of the GK point you can enter, yes.
So-
That,
oh,
yeah.
hang on. We're going to place filler like that.
Yes, but a little bit curved. When you go on your way out, try to angle the needle a bit, the bevel upwards while injecting.
So enter about here.
You can enter a little bit lower than the vermilion border, actually, so sub-vermilion border.
This looks up to me. Am I?
Yeah, you're sub there. Yes. Good.
Depth okay?
That's perfect. And
This is-
now angle your bevel upwards towards her nose a bit while injecting. Retrograde.
And that total volume of roughly what?
Like a fence. Point,
So
0.03. And now you can give her a squeeze like this,
Little-
other way.
So, okay, so like
Yeah.
to project the GK point.
Now lateral to the GK point. Yes.
Okay, this is a new
Yeah.
one to me.
Yeah. Give it a squeeze there. Nice. Let's see if something happens. I mean, sometimes it works. Sometimes you get a small improvement. Sometimes nothing happens.
It seems to me from my angle to be projecting outwards more.
Okay, good. She also got a little bit of a bleeding lateral to that flat area. So she's a little bit extra swollen there. So the flatter area looks more pronounced now because of that as well. And that's also coming with experience when we work with lips. What is swelling? What is bruising?
Okay, the other
Mhm.
side.
Next side. Well done.
So should we do the same injection again here?
No, she doesn't
No.
need it on that side. So you just need a
It's the
little
two,
plan in the corner. Yeah. The 2 ones.
entry.
Yeah. And close to the wet dry first. The lower injection first. And then you can angle up the needle on the second one. That looks great, Tim. Nice. Beautiful. And the last thing I would like you to do now in the upper lip is to stand behind Scarlett and look down. And you ask her to open her lips a little bit so you can see the wet-dry junction. And you look for irregularities there, for indentations. And if there is any irregularity, you correct that with micro droplets directly in the wet-dry junction, like small droplets. So you don't go from the vermilion border or from the middle of the lip. You just put your bevel exactly. Yes, I would add 1 drop there. And these should be very superficial. Well done. And this is how I do these droplets until the wet dry. I see on our other side, next to that little bruise, you could add another little drop. Yes, there. The bruise is giving some volume in that area, but I still believe she needs a drop there. And also at right next to her central tubercle, she has 2 little creases there. I would add 1 of these droplets in every crease in the lateral ones. Yes. Go in diagonal there. That's perfect. And here is also important, like Tim is doing, lifting up to see that is actually very superficial here. Beautiful. Here it can be a little bit sensitive for the patients. And 1 there on the other side. Beautiful. And these droplets I just leave because this is tissue integrative fillers, so they will integrate. Because if you now start molding these, they will just separate on each side of the midline fascia, and you can make these creases even deeper. So let it integrate by itself during the healing process. If the patient calls you a week or 2 after the treatment and she smiles and she can see these boluses, she can always do it like this and massage them flat towards her teeth during the healing process. They will flatten out nicely. Oh, look at that, Tim. I feel like they're so kissable. Beautiful. And now look how small the lower lip looks in it in comparison. How much have you used so far? May I ask?
That was 0.7, but I did waste a little bit. So
Yeah,
probably
you
about
wasted.
0.65.
Yeah, but we were focusing on height and volume in our upper for sure. What do you think so far, Tim?
Yeah, one of my tests is when I look back at the patient, you know, there's that subconscious part of your brain that responds differently.
Yeah.
You just feel that they're more beautiful.
Yeah.
So yeah, I had a bit of that. I've had that just quick glance over, and she looks even more beautiful than last time I looked.
Cool. That's beautiful. So if you're happy with the upper lip, I am very happy. We can go down to the lower, and then I would just start by doing the horizontal fanning, the volumization treatment to begin with on both sides. And then we make a decision at the very end if we want to do some fences in the medial third to pull it down in height. But we do the horizontal first. And
So,
here, yeah, here you want to enter so the bevel almost reach the midline fascia. Yes.
Okay.
Perfect.
Midway between wet dry border and
yes, correct. And again, a little bit deeper than the fences, a millimeter deeper. Still very superficial though.
total volume
I would say 0.1
in three strokes.
in 3, yeah. Beautiful. I would actually do one more in between those 2. It felt like the first one you did quite same there. Yes, perfect. That was actually about 0.1. Well done. And then you connect from the commissure. So think when you're injecting, like you're injecting in a network. So you don't leave any spaces, because if you leave any empty spaces, when the patients are healed and in animation, when they say ooh, for instance, they compress their muscle. If you left something here, the lip will fold in. That's why I always try to inject these fans in a very connective network all the way.
So lateral injection points.
Mm-hmm.
Similar approach again, with in between a smaller section.
Yes, and start close to the wet dry first, and then work yourself downwards.
And total volume.
I would say same as the upper lateral corner. 0.05. I'm usually very conservative with volume in the lateral corners, more working with the transition from the center and also for texture improvement in this area. Because if we add too much volume laterally in a female lip, they can look quite square and a little bit sausagey. And also often if you add too much lateral on the upper lip, they can get that crease here. It's not very satisfying, and that can get worse when they sleep on their side.
Yeah, this, if we have a look at the top view, this angle here in the lower lip is so beautiful, and it's one of, obviously, if you over treat laterally, you take it away. So
Exactly. They get that you turn downwards, and they can look a little bit more grumpy, and the lips looks less neat, in shape.
I'm just going to put another needle on.
Sure.
These lips remind me of Julie's Instagram feed. They look amazing.
They look great. I agree. Well done, Tim. These are going to be Instagram worthy for sure.
So we did 0.1 in total. I crossed all the way to the midline.
Yes.
So entering around here. This is also a variation on how I do it, but I'm liking what I see with the tubercle shape.
Cool.
So I'm going posterior, more superior one towards the wet dry border now.
Yeah, you can do that one, and then one downwards also closer to the vermilion border. Yes, that one. Perfect. Beautiful.
And then
Yeah. Close to the wet dry first, and then angle downwards, the second one. And again, 0.05 approximately. I feel also when I work in this very superficial layer of the lip, the closed compartment, I need often a little bit less product for a more visible result. And that also includes by creating more height, you get more visible result in a frontal view. Because if you inject deeper into the muscle, which can be a little bit more risky, I sometimes feel that like the filler just disappears in there. You don't get so much projection and visible result, on the surface or in the lip.
well, knowing you probably planned this, but that was exactly 0.1 mil, exactly 1 mil. So
Perfect. I did actually a little bit. Oh, look at those tubicles in her lower when she smiles. Beautiful. So when we now are going to see the ratio between the upper and lower lip, always sit your patients up. So the lower lip, we need the gravity sometimes. The lower lip can fall down a bit so we can properly see the ratio. Then we take the decision if we want to do a few verticals in her lower or not. When they lie down slightly, the lower lip falls a little bit into the oral cavity, and they always look upper dominating. So make them sit up a bit, let the lower lip fall down, and then you assess them from the front and the side. Do it has enough height? Does it have enough projection? Oh, hello, sexy. What do you think, Tim?
So there's a fair amount of swelling here in the top.
Oh,
lip.
yeah.
So-
And when we start with the top, it has more time to swell. We just finished the lower, so
Can we zoom up a little bit for?
yeah,
Julie?
zoom a bit. And I definitely have the same impression, like you said, Tim. She just overall, even though she's swollen, and this will look much better in a couple of weeks. When I look at Scarlett now, when I saw her before, I mean, she's beautiful. She's, I would say, beautiful and cute, but now she's sexy. And look at that smile. Smile again. Look at the gum, look at the more red lip show. Okay, the lidocaine will have some effect, but that is just beautiful. And I mean, you have now, Scarlett, transformed from a beautiful, sweet, cute woman to you're sexy now. That's the approach. Yeah. And that's how important lips are for us women, how we can just turn or, change emotions in the face by just highlight the lips a slightly bit. And also the color now. Many people think that I use, I don't know what, lipstick or tinted gloss. I never do. I'll show you here later what I use on my lips, and it's definitely no color on it. So the color comes from the trauma from the injections. It will fade. They will not be this red when they are healed, but often I get a color improvement also when I use non-hydrophilic filler, especially with Restylane Kiss. I see this. Profile, maybe just a little quick look there, or I can trust your judgment if it's difficult with the camera view. We have to keep in mind now that the upper lip is slightly more swollen than the lower lip. But you did add approximately 0.7 in the upper and 0.3 in the lower. So if you don't mind, Tim, to open another syringe, I would do a few more injections in her lower just to make sure she looks balanced.
So what I often do is just do with your hand and kind of see if it looks more balanced. At the moment, what I feel is a top lip is slightly dominating. So yeah. I agree. And there is swelling, but the swelling will be proportionate. So
yeah.
A couple of little small amounts in the lower lip to balance it.
I agree.
Okay,
and that little asymmetry you see now in the upper is that bruise on her right side that gives an extra volume there, and that will go away, of course.
Okay, can I have a light back in? Now, we will say this procedure is probably taking a little bit longer than it would in a clinic because we're doing a lot of teaching, so a lot longer. But so the swelling builds up a little bit more.
It does.
So,
sometimes when I have trainings here, some of my delegates wants to be my patients. So they sign up for that in advance, and then I inject them and their lips look like, very pretty immediately after. And then an hour goes and another hour goes, and I can see how they just grow and grow. Scarlett like, uh-oh.
Yeah. Okay. What are your thoughts? So the equivalent of the GK point, the lower lip angle.
Mm-hmm. You can start there and work yourself medial in towards the midline fascia, yes.
Okay, and then 0.03.
Yeah. Beautiful. Great. Yes.
Another one?
Yes.
How many we can do, just to give me an idea, sort of 1, 2, or more than that?
No more. I would do 2 more. Like a little bit more medial the next one. So don't too close together. So you can have a little bit space between the fences, like 3 millimeters or so. And you don't have to do so many. So the next one you do jump about 3 millimeter lateral. Yes. There, perfect. And another tip I can say in the meanwhile, while you do this fence, and do one more after this. If you go up and you add a bolus before you do your retrograde fence, you can build up more height of the tubercles in the lower lip, so they get more of that heart shape. And often that also gives them that keyhole in the center if you build up that height. I call it lollipop. So I go in just like you do now. I add a bolus and then follow by a linear thread. You get more of that heart shape height of the tubercles in the lower lip. Almost done now, Scarlett. Doing so well. And if you feel that you get any indentation now, flatter area when you did the vertical injections, you do this squeeze again towards the surface. So protect the injection points, yes, and squeeze towards the surface. These lips are start to look like the ones you have up in the corner there, your 8D lip design logo. Beautiful. I can see we have 73 questions in the Q&A, Tim.
So what do you think, Julie? Are you signing me off?
I'm signing you off now. Yummy.
All you women out there injecting, you can use so many words of description that I'm not allowed to use.
I know, we're spoiled there.
Everything is technically perfect, but inside I can say all the other things.
I have a great tip for male injectors out there and also women. If you have a patient that you can feel has a lot of integrity and he or she doesn't feel confident you being too close or leaning your arm over the patient, because when I work with lips, especially when I do the lower lip, I often have to rest my arm over the breasts of the patients. And I mean, the majority of patients still is women here. And if you are a male injector, I got such a great tip from my business partner, Felix Bertram. He says he asked the woman to do this. She feels protected. She protects herself. She's covering up her breasts. And then he can lean over her arms instead if he needs to have support there. So that is a really good tip also.
That is a really good tip. That saved me from hours of sore shoulders and hover hand. If only I'd known that 10 years ago. Okay, so you also mentioned in the facial assessment around the chin, and we talked a little bit, if we can get the chin in shot.
Yes.
Around getting the jawline to echo the lips, and that you can see it much more now that we've corrected the chin, that there's this little indentation. Mm-hmm. And if we can get her chin to basically match what we've done in the lower lip. So yeah. She has a small dimple, which she doesn't like. some people like them, some people don't.
Yep.
So we have permission to do a little bit of treatment there. Would you guys watching like to see a small chin augmentation as well? Give us
Yes.
a wave. Yeah. Okay. Are we, so before I slightly jumped ahead, are you're happy with lips now, Julie? You're happy?
I'm super happy. Yes.
Great.
And that little line you see here laterally, that shadow, that will go away when the swelling goes away. This one here. In some cases, some patients need some support there. You can do that squeeze test. And if they have very little support, I can go from above and just do a little superficial fan in that region here to smoothen out and give support and get rid of that line. Can often get worse if they sleep on their side. But I do believe this little chin augmentation here will do magic. Because it's actually changing the whole facial shape if you round the chin. So we will really feminize her features now with the lips and to round her more square-shaped chin with that dimple.
So chins are, I call them the cherry on the bottom.
Yes.
It makes a nice difference.
Cherry on the button, I like that.
So but you can apply everything we've just done with lips to doing a chin as well, which is that I'm first of all palpating the area. You can occasionally, it's obviously not the most sensitive test, but occasionally you'll feel a pulsation.
Yeah.
I can, usually if the patient's nervous, you can feel, and I can also feel that underneath here, the bone has a dimple in it, which you'd expect. This is the suture line in embryology. So it's just not a perfect closure. So there's a bony difference there, which can help the patient to know that. But I think we will almost certainly get this to project out. The other thing I like to do is, as I've said a few times, is just kind of shape it and see what I think aesthetically, if I make that difference. Does it fit from the frontal view? Because has she got room to make her chin slightly longer? She absolutely does now that she has slightly fuller lips.
Yes.
But it's also, in terms of a ratio, I don't think she's anywhere near breaking any ratio. So we can make it slightly longer.
Yes.
And the other thing you might want to do is have a look from the side profile and see if there's room for it to project outwards. So here you're looking at the facial plane and whether this chin is pushing up against the facial plane, ahead of it or behind it. And I think it's actually usually very attractive to have a slightly stronger chin than a lot of the textbooks say. Pushing slightly above that. We're probably not going to do that because I'm just going to correct this dimple.
You mean like this?
Yeah, exactly like Julie's chin.
They called me Jay Leno when I was younger.
Where are they now?
I could hurt someone with this. Stab someone.
So I show my age when I talk about these actresses, but I remember like Liz Hurley, Jennifer Aniston,
Oh yeah.
all those 90s stars. They have very strong chins and they break the ratio. So you can go a little bit strong, but here we're just going to continue her natural shape. And this is, I think chins are quite tricky in one way in that we have several different converging surfaces, and we're trying to get it to keep going in a way that's confluent with those other surfaces. So what I'm often thinking when I'm injecting is, how is this extra projection matching up with the leading lines leading into it? And you need to do that in 3 dimensions. If you do it from 1 dimension, you end up with a little bump underneath or a projection from the side that doesn't match. So
often I feel like in the pre-jol area, I need to go in with a cannula to give some support and volume here to give a nice transition over to the cheek area and the mandibular. So, chin also, they are very different. So we really need to pay attention to the rest of the face and the anatomical structures and assess properly. Yeah.
okay.
A good thing is to imagine you draw a line between the upper and lower lip. Ideally, we should have 1/3 in height above that line and 2/3 in height below that line. Then you have the optimal positioning of the lips in the lower face. And I think that is exactly what you're going to reach now when you do that little chin injection on her, that ratio.
So I'm palpating with my supporting hand. I like to get my position with with palpation whenever I'm injecting. So I can feel the inferior border, anterior surface, and then I'm sliding in midline, and I'm nice and slow until I touch the bone.
Mm.
And I like to palpate until I can feel that I'm on the apex of where I want to be. That's where I'm going to get the most effect.
Yep.
I'll do a little aspiration because why not?
Why not? Exactly.
Yes, this is Volex. So I shifted needle position slightly, so I've aspirated again.
Mm-hmm.
It's not a bad idea to shift a little bit when you're doing boluses on periosteum. Just it reduces the total volume in one spot, which is a risk.
Yes, great tip.
Okay. So the
Mm,
little dimple is
nice. Oh, beautiful.
It's almost like it was never meant to be there.
Yes. From my angle, she could have one in her right prejowl sulcus along the mandibular. Feels like, but it could be the light reflection from my side. But there, yes. How does it look from behind, comparison to the other side?
It is a little bit flatter.
Yeah.
But this is for those watching, a risky area for masculinization. So I'm very reluctant to do more than 0.1 on
Mhm.
its own, only because in the past I have, and then you end up with a slightly square shape.
Oh, yeah. Mm.
So is there room? Yeah, I think just for symmetry alone, there's an argument. So my style of doing this is also more likely on the bone.
Yeah.
Palpate left finger and right, above and below. Slide down.
Bless you, whoever it was.
I've got negative pressure on my syringe. I've just moved slightly. That's just a little extra bonus. One. And when I'm not squashing it, I'm a little bit above, a little bit below, shaping it so that
Yeah.
the product is where I want it to be.
Mm-hmm. Yes, it already looks better from my angle as well. Great. You planning to do something in her piriform there? Or is it just for
So
show?
well, one of the suggestions that came through the gummy smile element, which we may not have a gummy smile anymore,
Mm-hmm.
is 31. So very early signs of aging. And that's one of the things that it's at this age, it's very easy to take people back a couple of years. So slightly soften the nasolabial fold, maybe dampen down the elevation of those lip elevators. And the other thing I thought with the rest of the product is just create a little bit more angle on her cheek.
Mm-hmm.
I've sent Scarlett this on video. So it's to do with what we see so often with, well, it's a natural shape face, but the mid-cheek fat pad becomes more dominant and the lateral fat pads get less dominant. So the curvature of the cheek rotates slightly medially over time.
Mm-hmm.
So if I can restore a little bit, I call this focusing the cheek, not so as much as an augmentation. It's just the focus. I want to have an angle here that frames the eyes.
Mm-hmm.
So a little injection just here, may only take one, we'll see, as a beautifying, subtle, no one in a million years will think she's had her cheeks done. But
It's the nalar eminence you're thinking of, just to highlight that to get the light reflection to hit there more.
Yeah, well, it's the angle of the zygoma that I feel if you follow the curvature of her cheek, the greatest curvature is a little bit more medial than it probably was. Well, than perfect. So if I can get the curve to show through, it's basically definition, a defined little bit more definition to the cheek. Okay. Yeah. Now I'll point out to everyone watching that had she come in and asked for her lips to be done, and I'd said, yes, I'll do your lips and treated her, she'd be happy. But we did a full consultation, and I understand that she's seeking potential. And if you get to the point where your patient said, yes, I'm seeking my beauty potential, then you can have a much broader conversation about other things. And it's a service. It does not feel like a hard sell, which I know so many clinicians are afraid of. You are serving their needs. We're helping her feel on the front foot.
That's great.
If you told her about her cheeks without doing the consultation, then she feels criticized.
Mm-hmm.
So, you know, but now we're on her side. Okay. Give it a pencil just to mark out. None of this will be as you've done the worst bit with your lips. Did a great job. So let's do a little refresh. I'm sure many of you are treating nasolabial folds. I want to stabilize the lip elevators. So in my mind, this works much better with a deeper injection. And what we've got to be thinking about is facial artery, which tends to run in the fat, just lateral to the nasolabial fold before after the labial artery becomes the angular artery, but it's in the fat here. If we stay deep on the periosteum, it's very rare to find an artery there. But the injuries I've seen have come from the infraorbital artery more than the facial artery. So this is an angle that's, if you can see me, if I'm like that, that's a more dangerous injection over time. So I want to be at 90 degrees. I find this to be pointing away from the facial artery and away from the infraorbital artery.
Right.
There is a little nerve that comes down. The infraorbital nerve supplies your top lip, so it can be a little bit pinchy at the base.
Breathe in. Think of a little puppy. Well done. And now I see you're using Voluma for this.
To resist the movement, I want a stronger product.
Mm-hmm.
So if I touch periosteum, I always change the bone. I change the needle.
I do too. It gets extremely blunt.
Some people don't, and then they tell their patients that's just the layers of the skin making the crunchy noise. I've had lots of patients say, "Oh, it's normal. It's the," and then they were surprised, like it didn't crunch like last time. I'm only talking about Botox.
Mm-hmm.
Then they think I'm a genius because I changed my needle.
Also injecting on periost, I often warn my patients that they can hear a funny sound, like a waterfall in their head. Especially when you do temples also. When I do temples, I ask my patients to open their mouth as much as they can, like they are at the dentist office, to relax the temporal muscle. And when you do the swift point with needle, the gunshot technique, I experience it hurts less, creates less pressure. Just a little input I come up with right now.
I think these experiences when you get injected yourself are it's very easy to forget what it's like to be a patient.
Yeah.
And get into the routine of things and not realize. I mean, I remember treating a colleague who had told patients for years, "Oh yeah, your top lip might get numb after the injection," but never experienced it. And when she experienced it, she said it's really anxiety provoking to suddenly feel the whole of your top lip go numb when she'd forgotten, because, you know, so it's a,
True.
you're doing, you okay? Okay. Let's just- Okay. I think we're going to take a break. Well, we're not going to take a break. Let's call this a day because we've done, Scarlett is, she's been through enough, I think. I think the periosteal injections often upset the your emotion a little bit. She's feeling a little bit. Do you want a drink of water? Yeah.
Yeah.
Okay.
Take some good deep breaths also, Scarlett.
So we'll let Scarlett settle, and then we'll do the Q&A, and then we'll get some pictures if Scarlett's okay with that.
Great. Well done,
Okay.
Tim.
Thank you. Thank you very much, Scarlett. It's been amazing. Let's see if we can lower this bed. Oh, it's not- Right, so let's do the Q&A. I know we've got a lot of questions to get through. We're probably not going to get through all of them. Miranda is going to collate and find the ones that are most relevant to, and because obviously many of the questions will be similar or relate to the same point. We'll make sure we get as much out of the Q&A as possible while we get a photo.
Okay, let's go straight into the most popular, most frequently asked question, Julie, which is, please can you tell us about your numbing regime, which would involve the, am I calling it nerve block? Is that correct terminology? Can you give us some instruction?
Absolutely. Why don't I go get some stuff, a Q-tip, and I show inside.
Thank you.
All right. So when I do my numbing for my patients, I use 2% lidocaine, no epi or adrenaline. I do my first injection. I follow the canine tooth. Oh God, I hope I don't have any food in here now. It's fine. You know, the vampire tooth, the fang, that's the canine. I follow it up. There we go. And I go in, it's nearer here now, right in here. I don't know if you can see.
How deep are you putting the needle?
I put my bevel in, just the bevel.
Yeah.
And then I inject approximately 0.8 milliliter. I want to see a bleb growing. So I don't go up with my needle, just the bevel, and I see that bleb growing. So about 0.8 on each side above the canine tooth, just the bevel in the mucosa. You see that balloon start growing. So I do the lateral points first, and I give them a gentle massage. Don't push and massage hard because it haven't kicked in yet. It can be painful. So a gentle massage until these lumps disappears. You spread the lido a little bit in the area. And then the 0.2 I have left in the syringe, I put it right in the center here, behind this little skin flap. A 0.2 injection usually kills the Cupid's bow, because it's sometimes when you do the mucosa block only laterally, they can still feel a little bit in the Cupid's bow. And then I do the same thing in the lower lip, there, and then the last 0.2 right in the center. I numb the upper lip, and then I treat the upper lip. Then I numb the lower lip and treat the lower lip, because that's how quick the effect wears out when you do this specific technique with the numbing. If I would numb both upper and lower, and then I spend some time on the upper and then I go down, yes, ouch, they say, it starts to wear out. And most of my patients, I ask them, because if I try something new, I always experiment and see, you know, how the best result will be. So during a period, I ask all my patients to send me a message to report how long after the treatment did the numbing wear out, and the majority said 30 minutes.
Yeah,
So that's how I do.
it's worth pointing out that the way I was initially taught like 12 years ago, you're numbing all the muscles, and it's way, what you've described is a much more precise numbing of lip sensation. But I'm sure how reliable do you find it? Do you find that there's often areas that are still sensitive, or is it very reliable?
The corner can be a little bit sensitive. So when I do the very last, they tweak a little bit, but we are less sensitive the more lateral we go, more sensitive the more medial we go. So that's usually a piece of cake for them, that little pinch. And then, of course, we have the patients, I think 25% amongst patients with red hair color can need quite a lot of more dose of Lido sometimes than others.
Right.
Thank you. And what products are you using after treatment, Julie, in terms of, to present the lips well, all that kind of stuff? What's going on afterwards?
I prepared it because I knew these questions were coming. So if I have a patient coming, that most of my patients have their daily makeup on when they arrive, unfortunately, but that's the case. So when I do lips, I like to clean them properly, the whole lower face, everything, makeup on the cheeks, everywhere. And then after the treatment, I reapply a medical grade foundation in the perioral region. And I use a brand called Oxygenetics. They come in different shades. I think they have like 25 different colors. So I recommend to buy one very fair, one medium, and one dark. And then you can also take a little bit of each and every one, and you can blend it, and they can match most skin tones out there. I use a clean makeup sponge. So I apply the makeup on my glove like this. And then I tap it in the perioral region. Tap, 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 tap. I have gloves. Use a clean sponge. And then I just tap it like this around the lips first, down the chin, and then I go up and blend it with the patient's own makeup. Then I take a gauze, spray some alcohol, and I wipe the lips completely clean, just in case I got some makeup on the lips in the making. So clean the lips with some alcohol, and the last thing I put on is now I'm using something called Pomade Divine. I think it's made in UK even. It's a clear ointment. I believe it has some anti-inflammatory components in there. I use a Q-tip. Then I just tap it on the lips, and then you have a clean glove, and I just gently put it on the lips like this. So that's usually my aftercare procedure when the patients are wearing makeup when they come to the clinic. If they don't have any makeup on, then I usually just use the ointment on the lips after for hydration and comfort. The lips feels extremely dry and crepey after a lip treatment because of all the cleaning, the alcohol, the poking. Trust me, I've treated my own lips. It's a horrible feeling. Sometimes they even get stuck to each other. So to prevent the patient to go and, go in their purse and use their filthy old lip balm. I mean, seriously, just look at this one.
Happened.
I don't know. Yeah, I think it's some food actually right there. You prevent them to use this because that can cause infections. So I've done this procedure for 7 years, 8 years, never bumped into any issues regarding infections or granulomas or anything because of it. So it works well.
Thank you. Talk to us about size of BD syringe if you do use those.
I very rarely use them because and the reason for that is that I'm so used to working with the regular syringes that comes in the boxes and the 1/2-inch needles. But if I have an extremely thin lip, it can be tricky to use a 1/2-inch needle to work. So you get more precision with a BD syringe. The size of it, well, I have something here that I love these. I think they're sharper. The needle doesn't get as blunt as many others. I don't know if you hear me now when I run away, but why don't I just show you? Where are you guys? Well, that was typical. 1 second.
Any other questions I can take?
Yes, Tim, tell us about the volumes you used in chin and nasolabials.
So I did 0.2 in each nasolabial, and I think it was 0.2 in the chin. Let me just double check that because I have it here. Yes, that was correct. 0.2. You need a good, strong product for that chin. So the product I used was Juven & Bolox, which is a very good product for chins in my experience. But you know, any manufacturer should have something trying to emulate bone. And if you just want a small difference, 0.2 is about right.
And do you charge for consultations? Because people felt that that consultation was so in-depth and great, but long. Would you be looking to charge for that?
So you can take a deposit so that they turn up and then put that towards their treatment. But I don't charge for consultations because my conversion rate is like 95%. Almost everyone who has that consultation is very happy to have a procedure. Even people because this used to take me by surprise when I switched to this style of consultation, that I'd have people coming in, their friend was just in the neighborhood and I had a gap in my diary and they'd never heard anything about me, no social media. And I would do that consultation and they commit to spending like £2,000-4,000. And it used to surprise me because I didn't think people would do that. But the consultation is so good that they do it. So you will convert more people if you do that style of consultation. But by all means, take a deposit, but you'd surprise yourself. It's much better than you would think. It does still surprise me regularly when I get to the end of it and they say, sure, let's do it all.
Is there an approximate amount of filler, Julie, that you would suggest for each superficial fence?
That would be 0.03 milliliters. And if you look at a BD syringe, this is the typical classical one, the insulin syringe, 1 milliliter. It has a little bit longer needle. And 0.3 would be, or 0, it would be 1 fence.
We have Julie, yeah.
It would be this much from a BD syringe. That's approximately the amount. But what I wanted to say regarding the BD syringes, I see many are using this. That's great. Now I have black background there so you can see the length of the needle. But I found another brand, FMS. You can take a picture of the screen, everyone. Maybe I do it closer. So this is a 32 gauge. It's 0.3 milliliter. And it looks like this, pretty and purple. And the beauty with this is that I use it for toxin as well. And in my experience, the needle doesn't get blunt as quickly. And you can see also the tip is shorter. So for these very, very, very thin lips, this can be a really good, and it's even smaller, the syringe. So this is what I would say about the BD syringes.
Thank you. And can you talk about different products? So we know you are using the Restylane family. Would you use different products within the lip? And if so, why?
I would. For instance, if I have a patient coming in and first I always want to hear her story. Let's say it's a female, because that's the majority of my lip patients. She tells her story, what she wants with her lip, her goal with her lips and all that. I examine the tissue, but she has very loose tissue, little bit these wrinkly lips. lips with a lot of pockets, empty compartments. And then she asks for, I love that sharp definition. And I really want you to highlight my Cupid's bow. My Cupid's bow are very pointy. I would like it to be a little bit more heart-shaped. So in that specific case, I would choose a low G prime, high tissue integrative, soft, beautiful filler that is flexible into that wrinkly, baggy, empty area in the lips. And within the portfolio I work with Restylane, that would be Restylane Refine. And then I can go and do short micro fences. Instead of going from the GK all the way down here, I just go here. Choop, 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 choop. Short fences with a high G prime product with low tissue integration, and that would be classic Restylane L. So those two products I do combine quite a lot. So I don't inject that firm filler into the softer, more looser tissue. If you work with Teoxane, for example, because that's the product, the RHA range within the Teoxane is the products I believe that you can compare most to with the expression technology, or OBT as we call it in Europe, the RHA with Teoxane, and then RHA2 would be quite comparable to Restylane Refine. Of course, it's not the same, but it's the closest result I have experienced. It behaves quite similar.
Thank you. Claire says, does Julie usually inject down the Cupid's bow from the GK point? Are there any tips to create definition in this detailed and small area? And then someone else asked, what is the GK point?
So the GK point is the highest point of the Cupid's bow. So I can mark mine out now. There is one, and there is one. That's the GK point. And the question again was, the how to shape the Cupid's bow. Yeah. So yes, sometimes I go in here and I do a straight injection. I go in here and do a retrograde linear straight line if I need definition between the GK points. If the Cupid's bow is very pointy and they rather would have a softer, more heart-shaped one, instead of going in straight from the GK down to the midline fascia and do that line, I go and I do 1-2 short fences there to create some height there, and often then you can get more of that heart shape instead.
Thank you. Would there be a way to avoid top lip inversion with filler? I've noticed with older clients are difficult to avert the top lip.
Mm-hmm. It is difficult sometimes. I would say start trying with a little bit of toxin, wait a couple of weeks and bring them back and see if anything happened. Maybe they get a little bit of that lip flip, like we call. Sometimes it works, sometimes it doesn't. It's patient selection. And I really, I tell it to my patients. And also, because we don't know if it works or not, I charge very little for this lip flip treatment, just in case it doesn't work. Then if you see it works, you can charge much more the next time. No, just kidding. Miranda is laughing.
And forgive me, I'm slightly, I don't know whether I asked this already, but do you aspirate? And if not, or if you do, when? And if you don't, why?
So I rarely aspirate when I do lip injections because I move around my needle all the time. I have a good flow when I'm working, so I don't stand in one point and inject a lot of product. And I feel when in this soft tissue, when you aspirate, you often have to change the grip. And then when you aspirate and you change back, you are out in the position you were in to begin with. But if I need to do a little bit deeper injection that I was planning to, or if I feel tiniest amount of I'm not 100%, then I aspirate. Why not? It doesn't hurt. But always on periosteal injections, I do aspirate. When it comes to the rest of the face, to treat, I often use cannulas, and then I rarely aspirate. I think don't add too much bolus in one place. Move around a little bit when you work. Inject slowly. Always look at the tissue in the surrounding area when you inject, so you can catch discoloration, blanching, stuff like that. Yeah, that would be my answer. So I do aspirate. It never hurts to do that, but with lips only if I go slightly deeper than planned, and if I, feel that little, wait a minute, that I know entering into a vessel wall, I can aspirate. But yeah.
Thank you. Does the depth change with different products? Some people talk about certain products needing different depth injections.
Yes, I would say so. Depending on the rheology of the product, it's depending on where you can deposit it in the very, very delicate lip tissue. So some fillers, they don't behave very well in a very, very superficial layer. I would say, again, hydrophilic fillers, more rougher high G prime fillers doesn't either do very well in this very superficial layer of the lip. So then I would recommend to go slightly deeper, so you don't get nodules, visible nodules, Tyndall effect. Some fillers are more grainy in the consistency, like couscous, like I say. And like the Nasha range within Restylane, you have a higher risk of getting Tyndall effect, that blue shine, especially in the corner here in the lower lip. Is an area where the tissue often is extremely thin. And if you then create volume with a certain filler that tend to give Tyndall in a superficial layer, I would stay away from that product in that area.
Thank you. If there is a superficial artery above the muscle, can the patient still be injected safely?
Well, safely, I like to use low risk and high risk. And I do believe you can still do a low risk treatment, but I will definitely change my tool from a sharp needle to a little bit more fat blunt cannula. And I would slide careful in. If I get any resistance, I would never try to poke myself through the resistance. If I get resistance, I go back and I find another path, and then slowly retrograde injections. But that comes, if you feel like, oh, I don't know if I dare, I would rather refer the patient to someone else. Don't do anything that you feel uncomfortable with doing. That would be my suggestion. But I do believe you can treat these patients carefully if you are in the hands of an experienced injector that really knows the anatomy in the lips, which most injectors out there do. But if you are a complete novice injector and you see these arteries, I would recommend to maybe leave it for a while until you get more meat on your bones. And yeah.
Sure. And if you were using cannula, where would you enter?
Usually, yeah, I see many people enter like a centimeter outside the commissure. I normally enter more in the actual commissure.
M shape. Yes. When you often have more volume and projection of your central tubicle, less volume and projection in your lateral tubicles in the upper lip creates that inversion on each side. So it goes up, and down. So the line between the upper and lower lip is shaped like an M. And if the M shape is very severe, sometimes when the patient closes their lips, the central tubicle touches the lower lip first, so they get two gaps on each side. So you can literally see straight in on their teeth or to the teeth. So the goal with an M-shape correction would be to create a nice transition from the central tubicle all the way to the corner of the lip to create more like these old-fashioned curtains we had in our windows, that curtain shape So I do have a special technique for that as well, that I do with the M-shape correction, which really gives sustainable results. And what's important with M-shaped lips is that some patients, they will need more than one session to really improve, or in best case, even correct an M-shape. While some patients, maybe you can correct it with only one session, but it's important to let them know that it might be a journey. You might need repeated sessions to reach your goal. So it's really good to don't give unrealistic expectations, because that's often where we end up getting an unhappy patient at the end. Rather, let them be overwhelmed, like, oh darn, it happened in one treatment. I thought, then they get super happy.
I think we should wrap it up. It's been amazing having you, Julie, and you've given so much. I really enjoyed being trained again. I haven't actually done that for a long time now. It's really great getting an insight into all the detail that you are seeing as you're training. And I hope everyone got tons of value from that. Remember what I said right at the beginning. Don't just enjoy it, like make a decision, teach your patients more, try something new, get as much value out of this as possible, because that'll inspire you to keep learning more, and you don't mind investing in training when you know that you're going to implement. So just commit that to yourself now. You've taken the time and spent the money, get the most out of it by implementing. Okay.